Welcome to this Florida-mandated continuing education course on recognizing impairment in the workplace. This comprehensive program is designed for all Florida-licensed healthcare professionals and fulfills the biennial requirement established by Florida Administrative Code Rule 64B9-5.014 for nurses, with content equally applicable to physicians, pharmacists, physical therapists, respiratory therapists, physician assistants, and other licensed practitioners. The course content reflects current evidence-based practices and Florida-specific regulatory requirements, incorporating research from peer-reviewed literature published between 2020 and 2025. Healthcare professional impairment represents one of the most significant and challenging issues facing modern healthcare systems. The American Nurses Association historically estimated that 6 to 8% of nurses use alcohol or drugs to an extent sufficient to impair professional performance. This rate is comparable to the general population, but carries significantly greater implications for patient safety. When a colleague struggles with substance use disorders, mental health conditions, physical limitations, or cognitive decline, the consequences extend far beyond that individual. Patient safety may be compromised, team dynamics are affected, institutional liability increases, quality metrics may suffer, and the healthcare system's fundamental integrity is at stake. Yet impairment also represents a treatable condition. With proper intervention, most affected professionals can achieve recovery and return to safe, competent practice. This is not merely optimistic rhetoric. It is supported by substantial evidence. Research from physician health programs demonstrates that 78% of physicians have favorable outcomes at 5-year follow-up, with some programs reporting success rates as high as 92% for compliant participants. The Florida Professionals Resource Network, commonly known as PRN, has reported similarly encouraging outcomes for physicians who engage fully with their 5-year monitoring agreements. Florida has been a national leader in addressing healthcare professional impairment through rehabilitative rather than purely punitive approaches. On October 1, 1983, the Florida legislature established the Intervention Project for Nurses, known as IPN, making it the first alternative to discipline program in the nation. This pioneering program has served as a model for other states and has evolved over 4 decades to incorporate evidence-based practices in addiction medicine, mental health treatment, and professional monitoring. The Professionals Resource Network, serving physicians and other non-nurse practitioners, operates under the same statutory authority and provides comparable services. The purpose of this course is to equip healthcare professionals with the knowledge, skills, and resources necessary to recognize impairment in colleagues and respond appropriately. Recognition and intervention are not acts of betrayal or violation of collegial trust. They are expressions of professional responsibility and compassionate concern for colleagues in crisis. They are also, in many cases, legal obligations with consequences for failure to act. A systematic review analyzing 183 studies involving over 66,000 physicians found that the most common reasons for reluctance to intervene in addiction were lack of institutional support at 81%, lack of knowledge at nearly 72%, lack of skill at nearly 74%, and insufficient cognitive capacity to manage these complex situations at over 73%. This course addresses each of these barriers directly by providing the knowledge foundation, practical skills, and awareness of available resources that enable effective intervention. Early intervention demonstrably improves outcomes for impaired practitioners, protects patients from potential harm, and strengthens the integrity of the healthcare professions. Research on the Utah Professionals Health Program, studying 183 healthcare professionals enrolled between 2013 and 2024, found that return to use occurred in nearly 49% of participants, with the highest incidence of about 34% occurring during the first year of monitoring. This emphasizes the critical importance of early phase support and the reality that recovery is a process rather than an event. However, by year 5, over 81% had successfully completed monitoring and nearly 56% had returned to full-time healthcare practice, demonstrating that sustained recovery is achievable with appropriate structure, support, and accountability. Upon successful completion of this course, you will be able to classify the major categories of impairment affecting healthcare professionals, including substance use disorders, mental health conditions, physical impairments, and cognitive decline, with understanding of how these categories may overlap, interact, and present differently across professional disciplines and practice settings. You will be able to describe the risk factors and prevalence data for impairment among healthcare professionals across various clinical disciplines, including profession-specific patterns, demographic variations, and the impact of workplace factors such as access to controlled substances, high-stress environments, and shift work. You will learn to recognize behavioral, physical, and performance-related indicators of impairment in healthcare colleagues, including subtle early warning signs, documentation and medication discrepancies, and patterns that develop over time. Additionally, you will be able to explain the legal and ethical obligations for reporting suspected impairment in healthcare colleagues under Florida law and professional codes of ethics, including the rationale for mandatory reporting, liability considerations, and the primacy of patient safety. You will identify Florida-specific reporting requirements, processes, and protections for individuals reporting an impaired practitioner, including immunity provisions, confidentiality considerations, and the roles of the Department of Health and Professional Licensing Boards. You will learn to select appropriate intervention strategies and responses when encountering a suspected impaired colleague in the workplace, ranging from supportive peer conversation to formal reporting, with consideration of immediate patient safety concerns. Finally, you will be able to differentiate between the roles, functions, eligibility criteria, processes, costs, and confidentiality provisions of the intervention project for nurses, the Professionals Resource Network, employee assistance programs, and other available resources for impaired healthcare professionals in Florida. Let us begin with Module 1, which introduces the concept of impairment in healthcare settings. Impairment in healthcare refers to a condition that interferes with a practitioner's ability to practice with reasonable skill and safety. This definition, rooted in both clinical understanding and regulatory language, encompasses any physical, mental, or behavioral condition that diminishes professional competence to the point where patient safety may be compromised. Florida Statute 456.076 provides the legislative framework for addressing impaired practitioners, establishing programs designed to rehabilitate rather than merely punish healthcare professionals who develop impairing conditions. The statute recognizes that impairment often reflects illness requiring treatment rather than willful misconduct requiring discipline. It is essential to distinguish impairment from disability. A disability is a physical or mental condition that limits one or more major life activities and is protected under the Americans with Disabilities Act. Many healthcare professionals practice competently and safely with disabilities through reasonable accommodations. Wheelchair users, practitioners with controlled diabetes or HIV, those with managed mental health conditions, and many others contribute valuably to healthcare delivery. Impairment, in contrast, represents a functional limitation that currently affects the ability to practice safely, regardless of the underlying condition. A practitioner may have a disability without being impaired. Conversely, impairment may arise from conditions not typically considered disabilities, such as acute intoxication, severe fatigue, or medication effects. The four major categories of impairment affecting healthcare professionals are substance use disorders, mental health conditions, physical impairments, and cognitive impairments. Substance use disorders, including alcohol and drug dependence, affect reward pathways, judgment, and psychomotor function. Mental health conditions such as depression, anxiety disorders, bipolar disorder, post-traumatic stress disorder, and psychotic disorders may affect cognition, motivation, interpersonal function, and clinical decision-making. Physical impairments, including sensory deficits such as vision and hearing loss, mobility limitations, chronic pain conditions, and neurological disorders may affect the physical performance of clinical duties. Cognitive impairments, whether from neurodegenerative disease such as Alzheimer's or Parkinson's disease, traumatic brain injury, or age-related cognitive decline, affect memory, attention, executive function, and clinical judgment. These categories frequently overlap, particularly in cases of dual diagnosis where substance use disorders co-occur with mental health conditions. This pattern of co-occurrence is more common than isolated conditions. Understanding the prevalence of impairment among healthcare professionals requires acknowledging the significant underreporting that characterizes this issue. Healthcare workers are often reluctant to seek help due to fears about career consequences, and colleagues are often reluctant to report due to uncertainty about their obligations and concerns about damaging relationships. The American Nurses Association estimated in 1984 that 6 to 8% of nurses use alcohol or drugs to an extent sufficient to impair professional performance. This estimate, while dated, established a baseline understanding that substance use disorders affect a meaningful minority of the nursing workforce. More recent data from the Utah Professionals Health Program provides detailed insights into outcomes for healthcare professionals who enter monitoring. Among 183 healthcare professionals, 60% of whom were nurses, enrolled between 2013 and 2024, return to use occurred in nearly 49% of participants, with the highest incidence of about 34% occurring during the first year of monitoring. Factors significantly associated with return to use included younger age, longer duration of substance use disorder before program enrollment, and history of injury. By year 5, however, over 81% had successfully completed monitoring and nearly 56% had returned to full-time healthcare practice, demonstrating that with appropriate structure and support, most healthcare professionals with substance use disorders can achieve recovery. Mental health challenges among healthcare workers have reached crisis levels, particularly following the COVID-19 pandemic. A comprehensive meta-analysis of hospital healthcare workers during the pandemic found that over 28% experienced depression, nearly 29% experienced anxiety, over 25% experienced post-traumatic stress disorder, and over 25% experienced problematic alcohol or substance use. Among nurses specifically, studies have documented 48% burnout prevalence during the pandemic, with a 7-fold increase in depression and 4-fold increase in anxiety and stress compared to pre-pandemic levels. Surgeons show burnout prevalence rates of 30 to 60% across systematic reviews. A study of imposter syndrome among health service providers found 62% prevalence, contributing to additional psychological burden. Global data provide context for understanding the universal nature of this challenge. A study of healthcare workers in Kenya found that nearly 52% had ever used substances, with alcohol being most common at over 93% of those who use substances. While cultural and legal contexts differ significantly across countries, these data confirm that substance use among healthcare workers is not unique to any particular healthcare system or regulatory environment. Florida's large healthcare workforce, with over 400,000 actively licensed nurses and 90,000 physicians, means that even relatively small percentages translate to thousands of potentially impaired practitioners. The economic impact extends beyond direct patient harm to include costs associated with workforce turnover, professional liability claims, quality deficiencies affecting institutional reputation and reimbursement, and the substantial administrative burden of investigation and discipline. More importantly, untreated impairment exacts an immeasurable human toll on practitioners and their families, on colleagues who carry additional workload or face moral distress about whether to report, and on patients who may receive substandard care or suffer direct harm. Several factors unique to healthcare practice contribute to elevated impairment risk, creating what might be described as a perfect storm of vulnerability that requires systemic recognition and response. Access to controlled substances and pharmacological knowledge create opportunities for misuse that the general population simply does not have. A nurse or physician who develops pain can obtain opioids from workplace supplies rather than visiting a physician or pharmacy. A practitioner with pharmacological training may believe they can safely manage their own use. This belief often proves tragically mistaken as tolerance develops and dependence takes hold. A systematic review of physician reluctance to intervene in addiction identified lack of institutional support, lack of knowledge, lack of skill, and insufficient cognitive capacity to manage these complex situations as the most common barriers to addressing substance use in clinical settings. These barriers apply not only to treating patients with substance use disorders, but also to recognizing and addressing these conditions in colleagues. Institutions that fail to provide clear policies, training, and support inadvertently enable impairment to persist. The healthcare work environment itself poses substantial risks for developing impairing conditions. High-stress conditions, repeated exposure to trauma and death, chronic fatigue from extended shifts and insufficient recovery time, and the emotional demands of caregiving all contribute to vulnerability. Research on shift duration demonstrates that extended work hours directly impact both well-being and performance. Meta-analysis of 108 studies found that shift shortening to 24 hours or less was associated with improved resident well-being and stable patient safety outcomes, with significant 30-day mortality reduction for shifts of 16 hours or less, showing an odds ratio of 0.84. Mathematical modeling from the Rosters trial predicted significantly more time at moderate performance impairment for extended duration shifts of 24 to 28 hours compared to rapidly cycling schedules. Japanese studies of medical residents found that duty hours exceeding 90 hours per week were associated with shorter sleep duration and worsened insomnia, with insomnia rather than sleep duration alone predicting increased medical errors. These findings underscore that fatigue-related impairment is structurally embedded in many healthcare work environments. Research on sleep and wellness for otolaryngologists confirmed that chronic sleep deprivation contributes to burnout, cognitive impairments affecting clinical performance, and long-term health risks including cardiovascular disease, calling for systemic changes that prioritize adequate sleep. Professional culture compounds these environmental risks. Healthcare workers often minimize their own health needs, viewing them as less important than the imperative to care for patients. Perfectionism, endemic in many healthcare training environments, creates shame around any perceived weakness or need for help. Fear of stigma prevents early help seeking when treatment would be most effective. Concerns about career consequences, including license discipline, loss of hospital privileges, damage to professional reputation, and insurance credentialing difficulties, create powerful barriers to disclosure even when practitioners recognize they need help. A systematic analysis of barriers to physician mental health care identified stigma, fear of professional consequences, confidentiality concerns, and inflexible schedules as primary obstacles to treatment. These barriers prevent both self-referral and recognition and reporting of impairment in colleagues. The connection between provider impairment and patient harm is well documented across multiple domains of clinical practice. A systematic review examining stress effects on surgical performance found that acute stress consistently impairs both technical skills, including precision, efficiency, and tissue handling, as well as non-technical skills, including decision-making, communication, and situation awareness in both simulated and real-world surgical environments. The implications extend beyond surgery. Any clinical role requiring complex cognition, motor precision, or interpersonal skill may be affected by stress-related impairment. Drug diversion poses particular risks that extend beyond the impaired practitioner's own condition. A study of controlled substance theft in long-term care facilities documented over 11,000 tablets stolen from 368 residents, averaging more than 30 tablets per resident, with over 97% being controlled substances. Beyond the theft itself, diversion frequently involves tampering with medications, such as diluting injectable drugs, substituting saline for controlled substances, or partially removing tablets from unit dose packaging. This leaves patients to receive inadequate or no medication while believing they are receiving appropriate treatment. Patients may suffer uncontrolled pain, fail to achieve procedural sedation, or experience other treatment failures attributable to diverted medications. Social network analysis of controlled substance handling in emergency departments found nurses central to high-risk medication tasks, creating both essential accountability and diversion vulnerability. The circular network structure of medication handling provides redundancy that enhances safety, but also creates multiple potential diversion points. A case study during the COVID-19 pandemic documented a nurse diverting and diluting controlled substances while working under pandemic executive order waivers that relaxed certain surveillance requirements, illustrating how crisis conditions can create gaps in the monitoring systems designed to detect diversion. Cognitive impairment, whether from substance use, mental health conditions, fatigue, or age-related decline, affects clinical judgment in ways that may be difficult to detect until errors occur. Research on physician cognitive assessment found that physicians generally outperform the general public cognitively, with even 60 to 65-year-old physicians performing above the level of average 45-year-old non-physicians. This cognitive advantage, likely reflecting educational selection and occupational cognitive demands, means that standard age-corrected normative data may be inappropriate for identifying impairment in physicians. A practitioner performing normally for their age by general population standards might actually be functioning well below their profession-specific baseline. The second victim phenomenon adds another dimension to patient safety concerns related to impairment. When adverse events occur, including those related to impairment, medical personnel themselves often experience significant psychological harm, including guilt, shame, anxiety, depression, and even PTSD symptoms. Research on this phenomenon recommends peer support programs within institutions, recognizing that healthcare workers involved in errors require support to prevent cascading effects that may lead to their own impairment. This creates a cycle where impairment contributes to errors, errors contribute to psychological harm, and psychological harm may contribute to further impairment through maladaptive coping mechanisms, including substance use. The approach to impaired healthcare professionals has evolved dramatically over the past 4 decades, reflecting changing understanding of addiction, mental health, and effective intervention strategies. Prior to the 1980s, disciplinary action through license suspension or revocation was the primary response to identified impairment. This punitive approach proved counterproductive for multiple reasons. Practitioners hid their conditions until crisis made concealment impossible, often after patients had been harmed. Colleagues were reluctant to report, knowing that their report would end a career rather than initiate treatment. Many capable professionals were permanently lost to their professions when rehabilitation could have preserved their careers and their valuable contributions to healthcare delivery. In 1982, the American Nurses Association called on state nursing associations to develop alternative to discipline programs, recognizing that impairment often represents illness requiring treatment rather than misconduct requiring punishment. Florida responded with exceptional speed. On October 1, 1983, the Florida legislature established the Intervention Project for Nurses, making it the first such program in the nation. IPN has since evolved into a national model, frequently consulted by other states developing their own programs, and has served thousands of Florida nurses over 4 decades. The National Council of State Boards of Nursing subsequently developed guidelines establishing best practices for alternative to discipline programs nationally. The Professionals Resource Network, serving physicians and other non-nurse practitioners, operates under the same statutory authority found in Florida Statute 456-076 and provides similar monitoring and support services. The Federation of State Physician Health Programs has established standards for physician health programs nationally, promoting consistent approaches to evaluation, treatment, monitoring, and return-to-practice decisions. The evidence strongly supports this rehabilitative approach. Landmark research on physician health programs documented 78% favorable outcomes at 5-year follow-up, rates far exceeding general population recovery rates for substance use disorders. The Florida PRN has reported 92% success rates for physicians who comply with their 5-year monitoring agreements. These outcomes reflect the unique combination of factors present in professional monitoring programs. Participants have high motivation due to career preservation concerns. They typically have financial resources for treatment. They possess cognitive abilities supporting engagement with recovery concepts. They receive structured accountability through random testing and regular check-ins. They have access to peer support from other recovering professionals who understand the specific challenges of healthcare practice. A scoping review of alternative to discipline programs for nurses identified ongoing barriers, including cost, since participants bear substantial financial burden, abstinence requirements that limit access to medication, assisted treatment for some conditions, and lack of tailored options for diverse practitioner needs. Research continues on optimizing these programs while maintaining their documented effectiveness. Remember this key point: impairment is a treatable condition. Florida's IPN and PRN programs achieve recovery rates exceeding 90% for participants who engage with monitoring, demonstrating that early intervention and appropriate support can preserve careers, protect patients, and restore professionals to competent practice. The shift from punitive to rehabilitative approaches has proven both more humane and more effective. Now let us turn to Module 2, which focuses on substance use disorders among healthcare professionals. Substance use disorders affect healthcare professionals at rates that vary by profession, substance type, specialty, and study methodology. While overall rates of substance use may be comparable to or even lower than the general population for some substances, healthcare workers demonstrate distinctly different patterns of use, particularly with prescription medications to which they have occupational access. Understanding these patterns is essential for recognition and intervention. The Utah Professionals Health Program study of 183 healthcare professionals provides detailed insights into the trajectory of substance use disorders among monitored healthcare workers. Among those with substance use disorders, factors significantly associated with return to use included younger age at program entry, longer duration of substance use disorder before program enrollment suggesting more entrenched patterns, and history of injury which may relate to initial exposure to opioids for pain management. These risk factors have implications for identifying higher-risk individuals who may benefit from more intensive early support. Nursing presents particular challenges for substance use disorder, identification and intervention due to the profession's size, diversity, and medication access patterns. Nurses constitute the largest segment of the healthcare workforce and have frequent, often unsupervised access to controlled substances in many practice settings. Analysis of disciplinary actions reveals profession-specific patterns in how substance use disorder cases are handled, with differences in outcomes between nurses and physicians facing similar conduct. These differences reflect different regulatory structures, monitoring program designs, and professional culture expectations. The ratio of nurses in alternative programs relative to those facing traditional discipline varies significantly by state, reflecting different regulatory approaches, program accessibility, and awareness of alternative to discipline options. Physicians face unique vulnerabilities, including access to prescribing authority, specialty-specific exposures such as anesthesiology, which carries particularly elevated risk due to access to potent agents, and professional culture that emphasizes self-reliance and discourages help-seeking. Pharmacists have direct medication access and pharmacological knowledge that facilitates misuse. Allied health professionals, including physician assistants, nurse practitioners, physical therapists, and respiratory therapists, have varying degrees of medication access depending on practice setting. International data provide context for understanding the scope of the problem. A global study of healthcare workers in Kenya found that nearly 52% had ever used substances, with alcohol being most common among those who use substances. While cultural and legal contexts differ significantly across countries, these data confirm that substance use among healthcare workers is a universal challenge requiring systematic intervention strategies adapted to local contexts. Opioids represent a particularly dangerous category for healthcare professionals due to access, pharmacological knowledge, and the severity and speed of dependence that develops with these agents. Healthcare workers who develop opioid use disorder often begin with legitimate therapeutic exposure, treating their own pain with workplace medications obtained without appropriate prescription and monitoring, before progressing to problematic use characterized by tolerance, withdrawal, and loss of control. The progression may be rapid with potent synthetic opioids such as fentanyl. Research from physician health programs found that physicians with opioid dependence can achieve favorable outcomes when engaged in intensive monitoring programs. However, traditional physician health program approaches have faced criticism for limiting access to evidence-based medication-assisted treatment, including buprenorphine and methadone. A study of buprenorphine access found that 24% of patients did not reestablish care after provider disruption, with rural patients particularly affected. These findings have implications for healthcare professionals in recovery who require continued access to medication-assisted treatment. Federal policy changes following the Comprehensive Addiction and Recovery Act tripled buprenorphine prescribing rates and increased nurse practitioner prescribing by over 19% per month, improving treatment access. Alcohol use disorder remains the most common substance use disorder among healthcare professionals, consistent with patterns in the general population, but with particular workplace implications. The accessibility and social acceptability of alcohol, combined with high-stress work environments that normalize drinking as stress relief, create conditions conducive to problematic use. Unlike controlled substances that require workplace access, alcohol is readily available through commercial channels, making it harder to detect through medication discrepancy monitoring. Impairment from alcohol may be more likely to manifest as pattern changes over time, including absenteeism, declining performance, and relationship conflicts, rather than acute workplace incidents. However, coming to work under the influence certainly occurs. Benzodiazepines and sedative hypnotics are frequently misused for their anxiolytic and sleep-promoting effects. Healthcare workers experiencing chronic stress, anxiety, or sleep disruption from shift work may initiate use for ostensibly therapeutic purposes before developing dependence. The cross-tolerance between benzodiazepines and alcohol creates risks for polysubstance use. Benzodiazepine withdrawal can be medically dangerous, requiring careful management that may affect return-to-work timelines. Anesthetic agents pose unique risks for operating room personnel. Fentanyl, propofol, and inhaled anesthetics are highly accessible in surgical settings and can produce rapid, severe dependence. The mortality rate for anesthesia providers with substance use disorders is particularly concerning due to the potency and respiratory depressant effects of these agents. Propofol, which produces a brief euphoric state, has been associated with deaths among anesthesiology residents and nurse anesthetists who experimented with the drug. A case study during the COVID-19 pandemic documented a nurse diverting and diluting controlled substances while working under pandemic executive order waivers, illustrating how crisis conditions can create surveillance gaps that enable diversion. Stimulants, including amphetamines, often initially prescribed for ADHD, and cocaine are used by some healthcare workers to manage fatigue, enhance performance, or experience euphoria. The demanding schedules and extended hours characteristic of many healthcare roles create appeal for substances that temporarily enhance alertness. However, stimulant use disrupts sleep architecture, creating a cycle of stimulant use to function and sedative use to sleep. Cannabis presents evolving considerations as legal status changes across states. While Florida permits medical cannabis, healthcare professionals must understand that any substance affecting cognitive function or motor coordination may constitute impairment regardless of legal status, and that cannabis will be detected on workplace drug screening. Understanding addiction as a chronic brain disease is essential for reducing stigma and promoting appropriate intervention rather than purely punitive responses. The contemporary understanding of addiction has moved far beyond moral models that attributed substance use disorders to character weakness or lack of willpower. Addiction involves structural and functional neuroadaptations in the brain's reward, motivation, memory, and executive control circuitry that persist long after substance use ceases. This explains why sustained recovery requires ongoing support and why relapse, while not inevitable, is common and should be understood as a treatment indication rather than a failure. The mesolimbic dopamine pathway, extending from the ventral tegmental area to the nucleus accumbens, mediates the reinforcing effects of both natural rewards and addictive substances. Addictive substances hijack this system, producing dopamine surges far exceeding those produced by natural rewards such as food, social connection, or achievement. Repeated exposure produces neuroadaptations that diminish response to natural rewards, contributing to anhedonia and loss of interest in previously pleasurable activities. Simultaneously, these adaptations sensitize cue-triggered craving and compulsive drug-seeking behavior. Prefrontal cortex dysfunction impairs judgment, impulse control, and the capacity for consequential thinking. This explains why intelligent, well-educated healthcare professionals may make seemingly irrational choices when in the grip of active addiction. The executive functions normally exercised in clinical decision-making become subordinated to drug-seeking behavior. This neurobiological reality has profound implications for how we understand impaired colleagues. Their behavior reflects brain dysfunction, not simply poor choices, even as they retain responsibility for engaging with treatment and recovery. Genetic factors account for 40 to 60% of addiction vulnerability, with additional risk conferred by environmental factors including adverse childhood experiences, trauma exposure, and chronic stress. All of these may be common in the backgrounds of those drawn to helping professions and common in the occupational experience of healthcare practice. Healthcare workers may thus have above-average vulnerability to addiction while simultaneously having above-average access to addictive substances and pharmacological knowledge to manage their use, at least initially. The combination creates unique risk requiring occupation-specific prevention and intervention strategies. Several occupational factors increase substance use disorder risk, specifically for healthcare workers beyond general population risk factors. Medication access creates opportunity that other workers lack, specifically the ability to obtain controlled substances without visiting a prescriber, pharmacy, or illicit market. This access may lower the threshold for initial misuse, particularly for pain management or sleep, and facilitate escalation without external constraints. Occupational stress contributes substantially to vulnerability through multiple mechanisms. Healthcare workers witness suffering and death, make high-stakes decisions under time pressure, and face systemic pressures including understaffing, electronic health record burdens, productivity demands, and often inadequate compensation relative to educational debt. Research on emergency department healthcare workers found that doctors were most affected by stress, burnout, and compassion fatigue compared to other healthcare worker categories despite high empathy levels across all professions. Self-treatment behaviors pose particular risks unique to healthcare workers. Professionals with pharmacological knowledge may believe they can safely manage their own pain, anxiety, insomnia, or other symptoms using workplace or self-prescribed medications. This practice bypasses the safeguards of independent physician oversight, pharmacy monitoring, and controlled substance prescription databases that protect other patients from escalating use. What begins as occasional use to manage a legitimate symptom can progress to physical dependence before the healthcare worker recognizes the severity of the problem. Perfectionism and fear of stigma create barriers to help seeking that allow problems to escalate. Healthcare professionals often hold themselves to impossibly high standards while minimizing their own health needs as less important than patient care. The fear of career consequences, including license discipline, loss of hospital privileges, damage to professional reputation, and difficulty with insurance credentialing, may prevent early intervention when treatment would be most effective. Alternative to discipline programs were specifically designed to address this barrier by offering confidential pathways to recovery, but awareness of these options remains incomplete. Substance use disorders typically progress through recognizable stages, though the timeline varies considerably between individuals and substances. Early use and experimentation may be difficult to distinguish from normative behavior, particularly with alcohol. Problematic use is characterized by loss of control over amount or frequency, continued use despite negative consequences, and increasing time spent obtaining, using, or recovering from substances. Dependency involves physical or psychological reliance with tolerance and withdrawal. Crisis and detection often represent the point at which intervention finally occurs. A positive drug test, witnessed intoxication, medication diversion discovery, patient harm event, or arrest brings the problem to institutional attention. While crisis intervention is often effective, earlier detection would have prevented considerable harm. Remember this important point. Substance use disorders reflect neurobiological changes that impair judgment and impulse control. Healthcare professionals face elevated risk due to medication access, occupational stress, self-treatment behaviors, and barriers to help seeking. Understanding substance use disorders as brain diseases supports compassionate intervention, while recognizing that affected individuals retain responsibility for engaging with treatment and recovery. Now we will move to Module 3, which addresses mental health conditions and impairment. Mental health conditions represent a significant and often under-recognized source of impairment among healthcare professionals. Depression and anxiety disorders affect healthcare workers at rates equal to or exceeding the general population, with pandemic-era data showing marked increases that have not fully resolved. Meta-analyses of hospital healthcare workers during COVID-19 documented depression prevalence of over 28% and anxiety prevalence of nearly 29%, meaning that more than 1 in 4 healthcare workers experience clinically significant symptoms. These conditions have direct implications for both individual well-being and patient safety. Depression affects clinical practice in multiple ways that may not be immediately apparent to colleagues or supervisors. Cognitive symptoms including difficulty concentrating, indecisiveness, slowed thinking, and memory difficulties directly impact clinical decision-making. Fatigue and psychomotor retardation affect the physical performance of clinical tasks, particularly those requiring sustained attention or rapid response. Interpersonal withdrawal and irritability damage therapeutic relationships with patients and collegial relationships with team members. Anhedonia may manifest as apparent indifference to work that once provided satisfaction. Perhaps most concerning, depression is strongly associated with medical errors, creating patient safety imperatives beyond the humanitarian concern for affected colleagues. Anxiety disorders similarly impair clinical function through mechanisms that may paradoxically appear initially beneficial. Hypervigilance may initially seem like careful attention to detail in high acuity settings, but typically progresses to exhaustion, irritability, and decision fatigue. Avoidance behaviors may lead clinicians to defer or delay necessary clinical decisions, order excessive testing to manage uncertainty, or avoid patient populations or situations that trigger anxiety. Physical symptoms including tremor, palpitations, and sweating may be noticed by patients and colleagues. Generalized anxiety disorder, panic disorder, social anxiety, and specific phobias all present in the healthcare workforce with variable impact on specific clinical duties. Barriers to treatment for mental health conditions are substantial and well documented. Research identifying barriers to physician mental health care found that stigma, both self-stigma and perceived stigma from colleagues and institutions, fear of professional consequences including licensing questions, credentialing impacts, and career advancement implications, confidentiality concerns including uncertainty about whether treatment records could be accessed, and inflexible schedules creating difficulty attending appointments during clinical rotations or shift work prevented many from seeking needed care. The Dr. Lorna Breen Healthcare Provider Protection Act, enacted in 2022 following the suicide of an emergency physician during the COVID-19 pandemic, seeks to reduce these barriers through grants, supporting mental health programs for healthcare workers, and encouraging state medical boards to remove intrusive licensing questions about mental health treatment history that deter help seeking. A study of resident physicians who participated in a therapy program demonstrated significant improvements in professional fulfillment, self-compassion, and quality of life, with reductions in burnout and depression. This provides evidence that mental health treatment is effective for healthcare workers when accessible. Digital resilience interventions have shown promise, with mindfulness and cognitive behavioral therapy-based programs demonstrating benefit, though implementation research remains limited. Burnout has reached epidemic proportions in healthcare, with systematic reviews finding prevalence rates of 30 to 60% among surgeons and 48% among nurses during the pandemic, with elevated rates persisting in the post-pandemic period. Burnout is characterized by emotional exhaustion, which is the feeling of being drained and unable to face another day, depersonalization, which manifests as cynical and detached attitudes toward patients who are treated as objects rather than people, and reduced sense of personal accomplishment, which is the feeling that one's work doesn't matter or isn't effective. Burnout represents an occupational syndrome rather than a medical diagnosis, though its effects on practice quality, patient experience, and provider well-being are well documented. Burnout results from chronic workplace stressors that exceed coping capacity. These stressors include excessive workload, lack of control over work conditions, insufficient reward, whether financial, recognition, or intrinsic satisfaction, breakdown of workplace community, absence of fairness in institutional processes, and value conflicts between personal ethics and institutional demands. Organizational factors contribute significantly. Leadership support and adequate personal protective equipment availability were associated with decreased burnout, anxiety, and depression during the pandemic, while increased working hours were associated with increased mental health risks. These findings underscore that burnout is not simply a personal failing requiring individual resilience building, but a systemic problem requiring organizational intervention. Compassion fatigue, also termed secondary traumatic stress, arises from the cumulative emotional burden of caring for suffering patients. Unlike burnout, which develops gradually from workplace stressors, compassion fatigue can emerge acutely after exposure to particularly distressing patient situations. A scoping review of compassion fatigue among critical care nurses and physicians found low to moderate levels in most studies, with significant conceptual and methodological variability limiting definitive prevalence estimates. Research on Chinese nurses found that 31% reported low burnout, nearly 68% reported average burnout, and just over 1% reported high burnout. Secondary traumatic stress showed similar patterns with nearly 35% low, over 63% average, and under 2% high. Sleep quality, psychological capital, and social support were key protective factors. Qualitative research on emergency department nurses found that ongoing exposure to trauma resulted in moral injury and emotional exhaustion, with nurses creating micro-moments of psychological safety as coping strategies. The concept of digital compassion fatigue has emerged as a distinct syndrome affecting clinicians engaged in telehealth, with 6 defining attributes identified: emotional numbing, persistent exhaustion, compassion withdrawal, cognitive overload, professional inefficacy, and declining care quality. As telehealth becomes a permanent feature of healthcare delivery, this technology-mediated form of compassion fatigue requires attention in workforce wellness programs. Moral injury represents psychological damage from acting in ways that violate one's moral beliefs or from witnessing others doing so. It has gained recognition as a distinct contributor to healthcare worker distress that is conceptually different from burnout or PTSD. During resource-scarce conditions such as the pandemic, healthcare workers faced impossible choices. Which patients would receive scarce ventilators? When should visitor restrictions be enforced that separated dying patients from their families? How should personal safety be balanced against the imperative to care for patients without adequate protective equipment? These moral wounds persist even when clinicians intellectually understand they had no good options. They may contribute to substance use, depression, PTSD symptoms, and workforce attrition. Research on cognitive burden in emergency care identified 4 primary contributors to high cognitive mental workload: external demands including patient volume, interruptions, and system failures; excessive cognitive processing including information overload and complex decision-making; emotional demands including patient suffering, family distress, and death; and individual characteristics including experience level and coping style. High cognitive workload was associated with patient harm, near misses, burnout, compassion fatigue, and intention to leave the profession. This illustrates the interconnected pathways linking workplace conditions to both provider well-being and patient safety. Healthcare workers face frequent trauma exposure that the general population does not. This includes violent patients and visitors, graphic injuries and illness, pediatric suffering and death, mass casualty events, and the accumulated weight of bearing witness to suffering and death day after day. PTSD prevalence among hospital healthcare workers during the pandemic reached over 25%, suggesting that 1 in 4 healthcare workers may carry clinically significant trauma-related symptoms affecting their practice and well-being. While pandemic conditions were extraordinary, trauma exposure is endemic to healthcare practice. PTSD symptoms directly impair clinical function across multiple domains. Intrusive re-experiencing of traumatic events may occur during patient care that echoes past trauma. A pediatric code may trigger flashbacks to a child who died despite resuscitative efforts. A patient with injuries similar to a memorable trauma victim may provoke intense distress. Avoidance behaviors may lead clinicians to avoid certain patient populations, procedures, clinical settings, or even entire areas of practice that trigger symptoms. Hyperarousal symptoms including hypervigilance, which differs from appropriate clinical alertness, exaggerated startle response, sleep disturbance, and irritability contribute to fatigue, relationship difficulties, and impaired clinical presence. Negative alterations in cognition and mood may manifest as persistent negative beliefs about oneself or the world, detachment from others, including patients, or diminished interest in clinical work. Certain specialties carry elevated PTSD risk due to higher trauma exposure. Emergency medicine involves violence, critical illness, and death. Critical care involves prolonged dying, family distress, and moral distress. Trauma surgery involves graphic injuries and sudden death. Pediatrics involves child suffering and parental grief. Oncology involves repeated losses and end-of-life care. Psychiatry involves patient suicide and violence. However, any healthcare setting can produce trauma, and individual vulnerability varies based on personal trauma history, current life stressors, coping resources, and the presence or absence of workplace support. Suicide among healthcare professionals represents a crisis that demands attention and action. Physicians die by suicide at rates 1.4 to 2.3 times that of the general population, with female physicians at particularly elevated risk compared to women in other professions. This pattern inverts the general population gender ratio for suicide completion. Nurses, pharmacists, veterinarians, and other healthcare workers also demonstrate elevated rates. The combination of untreated mental health conditions, access to lethal means, particularly medications, knowledge of dosing for lethality, and professional culture that discourages vulnerability creates tragically high risk. Research on pediatricians illustrates the pervasive exposure to suicide that healthcare workers experience. 93% had a patient screened positive for suicidal ideation during their career. 81% had a patient who attempted or died by suicide. Yet 39% did not always screen for suicide risk. This data reflects both the prevalence of suicidality in patient populations and potential gaps in systematic assessment. For healthcare workers, repeated exposure to patient suicidality may normalize thoughts of suicide, reduce barriers to considering it, and provide knowledge about methods. Risk factors for healthcare professional suicide parallel general population risks, but include profession-specific elements. These include untreated or undertreated mental health conditions, often due to barriers to care, substance use disorders frequently co-occurring with depression, burnout, and moral injury, relationship difficulties exacerbated by demanding work schedules, and professional challenges such as malpractice litigation, loss of hospital privileges, licensing complaints, or public accusations that threaten identity and livelihood. Access to lethal means, particularly for physicians and pharmacists with medication knowledge and access, increases the lethality of suicide attempts. This means that suicidal crises more often result in completed suicide among healthcare professionals than in the general population. Barriers to mental health treatment contribute directly to suicide risk by preventing intervention when it could save lives. Fear of licensing consequences has been identified as a significant deterrent to help seeking, with some healthcare workers preferring to suffer in silence or die rather than create a record of mental health treatment that might be disclosed on licensing applications, hospital credentialing forms, or malpractice insurance applications. The Federation of State Medical Boards and other organizations have advocated for removing intrusive mental health questions from licensing applications, recognizing that such questions deter treatment seeking without meaningfully protecting the public from actually impaired practitioners. Co-occurring mental health and substance use disorders, known as dual diagnosis, are common among healthcare professionals, as they are in the general population, and likely more common than isolated conditions would predict by chance. The relationship is bidirectional and synergistic. Mental health conditions increase risk for substance use as individuals attempt to self-medicate distressing symptoms, using alcohol to manage anxiety, opioids to numb emotional pain, or stimulants to counteract depressive fatigue. Substance use worsens mental health through direct neurobiological effects on mood regulation, sleep, and stress response, as well as through indirect consequences on relationships, finances, professional standing, and self-concept. Dual diagnosis has significant implications for both detection and treatment of impaired healthcare professionals. Signs of one condition may mask or be attributed to the other. Depression may be attributed to substance use effects rather than recognized as a primary condition requiring treatment. Substance use may be rationalized as understandable self-medication for anxiety rather than recognized as a developing substance use disorder. Performance decline may be attributed entirely to burnout without recognition of underlying substance use or depression. Treatment must address both conditions concurrently for optimal outcomes. Treating only the substance use disorder while ignoring underlying depression, for example, increases relapse risk as the untreated depression continues to generate distress that previously was managed through substance use. Both IPN and PRN recognize and address dual diagnosis in their monitoring programs, understanding that effective intervention requires comprehensive assessment and integrated treatment planning. Participants may be required to engage in both addiction treatment and mental health treatment, with monitoring addressing both substance use through random drug testing and mental health stability through clinical assessments, therapy compliance verification, and psychiatric medication management as indicated. Remember this key takeaway: mental health conditions including depression, anxiety, burnout, compassion fatigue, moral injury, PTSD, and suicidal ideation are highly prevalent among healthcare professionals and represent treatable sources of impairment. Reducing stigma, removing barriers to treatment, supporting affected colleagues, and creating workplace conditions that protect mental health all contribute to both workforce well-being and patient safety. Let us now proceed to Module 4, which addresses physical and cognitive impairments. The healthcare workforce is aging, with significant numbers of practitioners continuing to practice into their 60s, 70s, and occasionally beyond. Normal aging produces subtle cognitive changes, including modest slowing of processing speed, mild working memory limitations, and occasional word-finding difficulties that do not typically impair clinical performance. Indeed, experienced practitioners often compensate effectively for these changes through accumulated expertise, efficient practice patterns, selective reduction of the most demanding activities, and use of cognitive aids such as checklists and decision support tools. However, distinguishing normal aging from pathological cognitive decline presents significant challenges, particularly in high-functioning individuals whose baseline cognitive abilities far exceed population norms. Research on physician cognitive assessment found that physicians generally outperform the general public cognitively across all age groups, with even 60 to 65-year-old physicians performing above the level of average 45-year-old non-physicians. This cognitive advantage, likely reflecting educational selection effects and the protective effects of occupational cognitive demands over a career, means that standard age-corrected normative data may be inappropriate for identifying impairment in physicians. A practitioner performing normally for their age by general population standards might actually be functioning substantially below their profession-specific baseline and their own historical performance level. Cognitive domains particularly relevant to clinical practice include attention and concentration, which are essential for monitoring multiple patients simultaneously and responding to interruptions without losing track of tasks. Executive function is required for clinical decision-making, prioritization, and adapting to unexpected situations. Processing speed affects response to rapidly changing clinical situations and efficiency of documentation. Episodic memory is necessary for remembering patient details, test results, and treatment plans across a shift or across multiple encounters. Procedural memory supports the skilled performance of clinical procedures. Deficits in any of these domains can compromise patient care even when other cognitive abilities remain entirely intact. Digital cognitive assessment tools are increasingly being studied for healthcare professional screening. The tablet-based cognitive assessment tool, known as TabCat, showed good convergent validity with traditional neuropsychological measures for early detection of cognitive change, representing a promising approach for physician health program screening or fitness for duty evaluation. Such tools may enable objective, standardized assessment that avoids the subjectivity and relationship difficulties inherent in colleague-based evaluation of cognitive function. Neurodegenerative diseases, including Alzheimer's disease, other dementias, Parkinson's disease, Lewy body dementia, and multiple sclerosis, can affect healthcare practitioners at any career stage, though risk increases substantially with age. Early symptoms are often subtle and easily attributed to stress, fatigue, normal aging, or the demands of practice, particularly by the affected individual, who may lack insight into developing deficits. This lack of insight is known as anosognosia. Colleagues may notice changes before the affected practitioner does, creating difficult interpersonal dynamics. Mild cognitive impairment represents a prodromal stage that may progress to dementia in some individuals while remaining stable or even improving in others. Healthcare practitioners with mild cognitive impairment may notice increased difficulty with complex clinical tasks that previously were routine, need for more time to complete documentation, new reliance on written reminders and checklists that previously were unnecessary, forgetting recent conversations or decisions, or difficulty keeping up with new information or practice changes. Colleagues may notice increased questions about routine matters, repeated mistakes in familiar areas, concerning clinical decisions, or personality changes including irritability, withdrawal, or uncharacteristic behavior. Movement disorders affect both cognitive and motor domains relevant to clinical practice. Parkinson's disease produces not only the characteristic tremor and bradykinesia, but also executive dysfunction, processing speed impairment, visuospatial deficits, and eventually dementia in many cases. The motor symptoms may affect procedural skills including surgery, physical examination, and procedures requiring fine motor control. Multiple sclerosis commonly affects processing speed, attention, memory, and executive function, with symptoms that may fluctuate based on disease activity. These conditions require individualized assessment of specific clinical duties against specific functional capabilities, often with occupational medicine and neuropsychological input. Physical disabilities require careful distinction from impairment, as these concepts are related but not synonymous. Under the Americans with Disabilities Act, qualified individuals with disabilities who can perform essential job functions with or without reasonable accommodation are protected from discrimination. Many healthcare professionals practice competently and safely with disabilities through appropriate accommodations. Wheelchair users who can perform cognitive functions of medical practice, practitioners with controlled chronic conditions who manage their health effectively, those with sensory impairments who use assistive devices, and many others, contribute valuably to healthcare delivery and often bring unique perspectives from their lived experience with disability and the healthcare system. However, some physical conditions do constitute impairment when they prevent safe clinical practice regardless of accommodations. Progressive sensory loss in vision or hearing may reach a point where clinical assessment is compromised despite optimal assistive devices. Chronic pain conditions may require medications that affect cognition, or the pain itself may impair concentration and judgment. Mobility limitations may prevent response to emergency situations requiring physical intervention. Conditions affecting fine motor control may compromise procedural skills. The determination of impairment versus disability with accommodation requires individualized functional assessment against specific job requirements, not categorical judgments based on diagnosis. Fitness for duty evaluations help determine whether an individual can safely perform specific clinical duties given their current functional status. These evaluations, typically conducted by occupational medicine specialists with input from relevant medical specialists, assess functional capacity against detailed job requirements. They may recommend accommodations that enable continued practice, practice restrictions that limit scope to areas of competence, or in some cases, conclusion that continued practice is not safe. IPN and PRN may require such evaluations as part of their monitoring programs when physical conditions are at issue. Fatigue represents one of the most pervasive impairment risks in healthcare, affecting virtually all practitioners at some point in their careers and embedded structurally in many healthcare work environments through scheduling practices, on-call requirements, and cultural expectations. The physiological effects of sleep deprivation on cognitive function are well documented and sobering. After 17 to 19 hours of wakefulness, performance decrements are comparable to blood alcohol levels of 0.05%. After 24 hours without sleep, performance approaches levels seen at legal intoxication of 0.10%. Yet healthcare workers routinely work shifts that produce these levels of impairment. Meta-analysis of 108 studies on shift duration effects found that shift shortening to 24 hours or less was associated with improved resident well-being and stable patient safety outcomes. Importantly, shorter shifts did not worsen patient safety, despite concerns about handoff-related errors. More dramatically, shifts of 16 hours or less were associated with significantly reduced 30-day mortality, with an odds ratio of 0.84 providing direct evidence linking resident work hours to patient survival. Mathematical modeling from the Rosters trial predicted significantly more time at moderate performance impairment for extended duration shifts of 24 to 28 hours compared to rapidly cycling schedules, with performance declining from weeks 1 and 2 to weeks 3 and 4 as cumulative fatigue accumulated. Japanese studies of medical residents provide additional insight into the relationship between work hours, sleep, and errors. Duty hours exceeding 90 hours per week were associated with shorter sleep duration and worsened insomnia. Critically, medical errors increased only among residents with insomnia symptoms, not those with short sleep duration alone. This suggests that sleep quality may be as important as sleep quantity and that insomnia assessment should be part of fatigue management. Research on otolaryngologists confirmed that chronic sleep deprivation contributes to burnout, cognitive impairments affecting clinical performance, and long-term health risks including cardiovascular disease, calling for systemic changes prioritizing adequate sleep. Shift work and circadian disruption compound acute sleep deprivation effects. Night shift workers experience misalignment between their work schedules and circadian biology, producing chronic partial sleep deprivation even when total sleep time appears adequate because daytime sleep is typically shorter and less restorative than nighttime sleep. The health consequences of chronic circadian disruption include increased risk of cardiovascular disease, metabolic syndrome, and certain cancers. The performance consequences include impaired vigilance, slowed reaction time, and increased error rates during the circadian nadir, which typically occurs between 3 and 7 in the morning. Institutional responsibility for fatigue management is increasingly recognized in healthcare policy and regulation. Duty hour restrictions for residents, while imperfect, acknowledge institutional obligations. Scheduling practices, on-call requirements, and cultural expectations around working while exhausted all contribute to fatigue-related impairment risk. Individual practitioners bear responsibility for reporting for duty in condition to practice safely, including calling in when too fatigued to work safely. But institutions bear responsibility for not creating conditions that predictably produce unsafe levels of fatigue and for supporting clinicians who prioritize safety over excessive work expectations. Many commonly prescribed medications affect cognition in ways that may compromise clinical practice, creating impairment risk even when medications are taken as prescribed for legitimate indications. Benzodiazepines impair memory encoding and psychomotor performance with effects that persist beyond subjective sedation. Anticholinergic medications, found in many antihistamines, antidepressants, antipsychotics, and medications for overactive bladder, produce cumulative cognitive effects including confusion, memory impairment, and increased dementia risk with long-term use. Opioids, even at therapeutic doses for legitimate pain, affect concentration, reaction time, and judgment. Antihistamines cause sedation and impaired alertness. Muscle relaxants, anticonvulsants, and numerous other medication classes carry cognitive side effects that practitioners may not fully appreciate. Polypharmacy, which is the use of multiple medications, compounds individual drug effects through additive effects, drug-drug interactions, and the complexity of managing multiple medication schedules. The Electronic Frailty Index, developed for primary care screening, found that severely frail individuals had 9 times more healthcare visits and 9 times the odds of polypharmacy compared to non-frail individuals. While this research focused on patients, the finding illustrates the bidirectional relationship between medication, burden, and health status that may affect aging healthcare professionals managing multiple health conditions. Healthcare professionals using prescribed medications with cognitive effects bear responsibility for understanding how those medications affect their specific clinical duties, monitoring their own function while medicated, and disclosing such use to supervisors when appropriate. Workplace policies regarding disclosure vary by institution and may depend on the nature of clinical duties. When in doubt, consultation with occupational health or employee health services can help determine fitness for specific duties while maintaining appropriate confidentiality protections. Remember this key point: physical and cognitive impairments require individualized assessment against specific job requirements. Not all physical limitations constitute impairment, and many conditions can be accommodated. However, fatigue embedded in healthcare scheduling practices represents a pervasive impairment risk, and age-related cognitive changes require assessment against profession-specific norms rather than general population standards. Now we move to Module 5, which covers recognizing signs and symptoms of impairment. Recognizing impairment in colleagues begins with attention to changes from baseline functioning. Behavioral indicators often emerge before obvious performance deficits, providing opportunities for early intervention that can prevent patient harm and improve outcomes for the affected colleague. The challenge lies in distinguishing concerning patterns from normal variation, temporary stress responses, or personal circumstances that do not constitute impairment. Systematic attention to behavioral domains increases detection sensitivity. Changes in interpersonal relationships and communication patterns merit attention. Watch for withdrawal from colleagues and reduced participation in team activities that previously engaged the person. Look for increased conflict with coworkers, supervisors, or patients. Notice inappropriate emotional reactions to routine work situations, such as excessive anger at minor frustrations, tearfulness, or flat affect. Pay attention to defensiveness when asked about well-being or work performance. A previously collegial individual becoming isolated or irritable warrants concern, particularly if the change is persistent rather than situational. Mood instability suggests possible mental health or substance use conditions. Watch for mood swings between elation and depression, unpredictable emotional responses that do not match circumstances, excessive tearfulness, or inappropriate affects such as laughing at sad situations or showing indifference to concerning events. Euphoria that seems out of proportion to circumstances may indicate intoxication from stimulants or alcohol, while flat affect may indicate depression or sedative effects. Defensiveness and denial when concerns are raised is characteristic of many impairing conditions, but particularly of substance use disorders. When colleagues or supervisors express concern, impaired individuals often respond with minimization, such as claiming they had only one drink, externalization of blame, such as claiming the patient was difficult, elaborate explanations that do not quite fit the facts, or aggressive counter-accusations. This defensive response differs markedly from the openness and appropriate concern that typically characterize individuals who made innocent errors and want to prevent recurrence. Personal appearance changes may reflect deteriorating self-care associated with depression, active substance use, or declining functional status. Watch for deterioration in grooming and hygiene, changes in professional dress, and significant weight changes, either loss or gain, as well as physical signs of poor health maintenance. While appearance changes have many potential explanations, they warrant attention in combination with other indicators. Physical signs of impairment vary by cause, but often provide observable evidence of concerning conditions. For substance use disorders, physical signs may be most apparent during intoxication or withdrawal states. Signs of acute intoxication include slurred speech, unsteady gait or impaired coordination, difficulty concentrating or following conversation, drowsiness or nodding off, and inappropriate behavior with reduced inhibitions. The odor of alcohol is obvious when present, but many other substances of abuse produce no characteristic odor and may be used without producing obvious intoxication. Signs of withdrawal may be more subtle but equally concerning. These include tremors, particularly of the hands, sweating disproportionate to environment, anxiety and restlessness, tachycardia and elevated blood pressure, and general malaise. Healthcare workers experiencing withdrawal may claim viral illness to explain symptoms, request light duty or early departure, or make frequent bathroom visits to manage symptoms or use substances to abort withdrawal. The pattern of these symptoms, particularly their timing in relation to work schedules, may be revealing. Pupillary changes provide objective physical evidence. Miosis or constricted pupils suggest opioid use, while mydriasis or dilated pupils may indicate stimulant use, withdrawal from certain substances, or anxiety. Pupil examination is unobtrusive and can be conducted in normal clinical interaction. Frequent bathroom breaks may indicate need to use substances, manage withdrawal symptoms, or conceal drug use behaviors. Long sleeves worn in inappropriate settings, such as warm environments, or situations where short sleeves are standard, historically suggested hiding injection sites, though this sign is increasingly uncommon as prescription diversion and intranasal routes have become more common than injection. For cognitive impairment from any cause, physical signs may include word-finding pauses in conversation, confusion about routine matters that should be automatic, getting lost in familiar locations such as the wrong floor or the wrong unit, forgetting recent conversations or repeating questions, and difficulty following multi-step instructions. These signs may be subtle and intermittent early in cognitive decline, but become more consistent as conditions progress. Declining work performance often provides the most concrete evidence of impairment and the strongest basis for intervention, because performance concerns can be documented objectively and discussed in professional terms without making personal accusations. Performance indicators span multiple domains of clinical practice. Increased errors and near misses warrant attention. Medication errors, documentation errors, missed diagnoses, procedural complications, and patient complaints that represent a change from previous performance patterns all merit concern. Individual errors may have innocent explanations since everyone makes mistakes and complex systems produce errors even with competent practitioners. But patterns of errors, particularly errors of types the practitioner previously did not make, require investigation. Near misses caught by safety systems such as pharmacist interventions, nursing double checks, and computerized alerts may be even more informative than actual harm events. Productivity decline manifests as seeing fewer patients, taking longer to complete familiar tasks, falling behind on documentation, requiring more time for procedures that were previously routine, or failing to complete expected work volume. This must be interpreted in context since reasonable pace variation exists and quality should not be sacrificed to volume. But significant decline from an individual's established baseline warrants attention. Attendance problems include patterns of tardiness, particularly on Mondays or after weekends, calling in sick with suspicious frequency or timing, leaving early, unexplained absences during shifts, and excessive use of FMLA or sick leave. All of these may indicate impairment from any cause. Patterns are more significant than isolated incidents. Clinical judgment concerns manifest as inappropriate orders that colleagues question, failure to recognize deteriorating patients, delays in responding to emergencies, treatment plans that do not match diagnoses, and decisions that experienced colleagues find concerning. These may be difficult to raise directly with the affected practitioner, but represent serious patient safety concerns. Medication handling irregularities are particularly significant warning signs for substance use disorders involving controlled substances and merit close attention. Drug diversion often leaves documentary traces that can be detected through systematic monitoring. Social network analysis of controlled substance handling in emergency departments found nurses central to high-risk medication tasks, including withdrawal from automated dispensing cabinets, administration, waste documentation, and returns, creating both accountability and surveillance opportunity. Wasting discrepancies include unusual patterns in controlled substance waste documentation, such as frequently wasting large amounts, always having the same witness who may be colluding or inattentive, discrepancies between documented waste amounts and expected volumes based on patient doses, and waste documentation that does not match clinical indication, such as wasting half of a dose when the full dose was ordered and there is no documentation of dose reduction. Modern automated dispensing cabinets track withdrawal and administration patterns that can be compared across practitioners to identify outliers. Medication count irregularities include controlled substance counts that do not reconcile, missing medications with no documentation, unexplained losses from automated dispensing cabinets, and discrepancies between withdrawals and administrations. All warrant investigation. Patient complaints of inadequate pain relief despite documented adequate medication may indicate diversion through substitution or dilution. A study of controlled substance theft in long-term care facilities documented over 11,000 tablets stolen from 368 residents, averaging more than 30 tablets per resident, with over 97% being controlled substances. This illustrates both the scope of the problem and the vulnerability of certain patient populations. Documentation alterations, including changes to medication records after the fact, late additions that do not follow documentation flow, corrections that use unusual processes, and records that do not match witness recollection, all warrant attention. While documentation corrections are sometimes legitimate, patterns of alterations around controlled substance records are concerning. Individual incidents rarely justify impairment conclusions by themselves. Pattern recognition is essential for appropriate intervention. A single late arrival may reflect traffic, but repeated tardiness suggests a pattern. One medication error may be unavoidable in complex systems, but multiple similar errors warrant investigation. The progressive nature of most impairing conditions means that early signs are subtle and easily dismissed, often rationalized by both the affected individual and observing colleagues, becoming more apparent only as the condition advances. Effective pattern recognition requires documentation of specific objective observations, including dates, times, and behaviors, witnessed rather than interpretations. It requires comparison to the individual's baseline functioning, asking how this person has changed. It involves consideration of contextual factors such as personal stressors, workload changes, and health issues. It benefits from input from multiple observers when possible, since patterns visible to one person may be visible to others. And it requires willingness to connect concerning observations that individually seem minor but collectively suggest a pattern. Not all concerning observations indicate impairment requiring formal intervention, and differential considerations are important for appropriate response. Medical conditions may mimic impairment. Hypoglycemia produces behavioral changes resembling intoxication. Thyroid disorders affect mood and cognition. New medications may have unexpected effects. Neurological conditions may produce confusion or coordination difficulties. Personal crises, including divorce, family illness, bereavement, and financial difficulties, may temporarily affect work performance without constituting impairment requiring formal intervention, though support should be offered. The appropriate response depends on careful assessment of the situation. When acute impairment poses immediate patient safety risk, the priority is removing the individual from patient care regardless of the cause. When patterns suggest possible impairment without immediate safety concern, supportive conversation may be appropriate before formal reporting, though this should not substitute for reporting when required. When cultural or personal factors may be influencing observations, care is needed to avoid assumptions or bias that could lead to disparate treatment. Remember this key point. Recognition of impairment requires attention to behavioral, physical, and performance changes over time, with systematic documentation of objective observations. Single incidents should be documented, but typically do not justify conclusions. Patterns of concerning observations warrant action. Differential considerations are important, but when patterns suggest impairment, patient safety requires action even without certainty about the cause. We now transition to Module 6, which covers legal, ethical, and professional obligations. Florida law establishes mandatory reporting requirements for suspected practitioner impairment that apply to licensed healthcare professionals. Under Florida Statute 464. 018 for nursing and similar provisions in other practice acts, Licensed healthcare professionals are required to report colleagues whose practice they reasonably believe may be impaired. This is not a discretionary decision based on personal comfort or relationship concerns. It is a legal obligation carrying potential consequences for failure to report, including discipline of your own license. The reporting threshold is reasonable suspicion, not certainty. You are not required to diagnose your colleague, prove impairment, or conduct an investigation before reporting. That determination is made through appropriate evaluation processes by qualified professionals. Your obligation is to report observations that give you reasonable grounds to believe practice may be impaired. The standard is what a reasonable professional in your position would conclude from the available observations. Waiting for certainty may mean waiting until a patient is harmed. Reports may be made to the Florida Department of Health, to the appropriate licensing board such as the Board of Nursing, Board of Medicine, or Board of Pharmacy, or directly to IPN for nurses or PRN for other practitioners. Reporting to IPN or PRN first may provide a pathway to voluntary monitoring rather than discipline, potentially protecting the colleague's career while ensuring patient safety. However, this option depends on specific circumstances, the individual's willingness to engage with the program, and the nature and severity of the impairment. Penalties for failure to report can include discipline of your own license. The nursing board and other licensing boards have authority to discipline practitioners who knew or should have known of a colleague's impairment and failed to report. This provision reflects the profession's collective responsibility for maintaining standards and protecting patients. It is not sufficient to assume someone else will report, to delegate reporting responsibility, or to rationalize inaction based on uncertainty. Florida Statute 456.076 establishes the framework for impaired practitioner programs that forms the foundation of Florida's approach to professional impairment. This statute authorizes the Department of Health to contract with approved treatment providers for evaluation, intervention, referral, and monitoring of impaired practitioners. It establishes confidentiality protections for program participants who comply with their monitoring agreements, protecting both privacy and professional reputation for those who engage successfully with recovery. It also defines circumstances under which confidentiality may be breached, primarily when participants fail to comply with program requirements. Florida Statute 464.018 sets forth grounds for disciplinary action against nursing licenses, including being unable to practice nursing with reasonable skill and safety by reason of illness or use of alcohol, drugs, narcotics, chemicals, or any other type of material, or as a result of any mental or physical condition. It also includes testing positive for any controlled substance on pre-employment or employer-ordered drug screening without a valid prescription and legitimate therapeutic indication. Similar provisions exist in other practice acts covering physicians, physician assistants, pharmacists, and other licensed professionals. Florida Administrative Code. Rule 64B9-5.014 establishes the continuing education requirement that this course fulfills. Nurses must complete a board-approved course on recognizing impairment in the workplace during each biennial licensure period. This requirement reflects recognition that all nurses share responsibility for identifying potentially impaired colleagues and taking appropriate action, and that this responsibility requires specific knowledge and skills that cannot be assumed from general nursing education. Beyond legal requirements, professional codes of ethics impose obligations regarding impaired colleagues that reflect core professional values. The ANA Code of Ethics for Nurses addresses the nurse's duty to protect patients from impaired practice and to take appropriate action when colleagues' practice is questionable. The emphasis is on patient safety as the paramount concern, while also recognizing the affected colleague's right to appropriate assistance and rehabilitation. The AMA Code of Medical Ethics similarly addresses physician obligations regarding impaired colleagues, calling for intervention to protect patients while treating the affected physician with compassion. Other professional codes for pharmacy, physical therapy, respiratory therapy, and physician assistants contain comparable provisions. The ethical tension between loyalty to colleagues and duty to patients is resolved clearly in professional ethics. Patient safety takes precedence. However, this does not mean that concerns about colleagues are dismissed or that reporting is equivalent to betrayal. The goal is to protect patients while also providing pathways to treatment and recovery for affected colleagues. Alternative to discipline programs operationalize this balanced approach, and referral to such programs represents an act of professional responsibility that may preserve a colleague's career rather than end it. All impairment-related decisions ultimately center on patient safety. When an impaired practitioner is providing patient care, patients are at risk. This risk must be eliminated or mitigated, regardless of the practitioner's intent, years of excellent prior service, personal circumstances, or the difficulty of the situation for those who must act. Compassion for the affected colleague cannot override the duty to protect patients. Failure to report suspected impairment can result in both regulatory consequences, including discipline of your own license and civil liability. If a patient is harmed by an impaired colleague whose impairment you knew or should have known about and failed to report, you may share liability for that harm under theories of negligent failure to report or breach of professional duty. Courts have increasingly recognized that those who enable impaired practice through silence, cover-up, or failure to act bear responsibility alongside the impaired individual. Immunity protections exist for good faith reporting and are important to understand for those who may fear retaliation or litigation. Florida law provides immunity from civil liability for individuals who report suspected impairment in good faith, even if the report is ultimately not substantiated by investigation. This protection recognizes that encouraging reporting requires protecting those who report from retaliation or defamation claims by the reported individual. The key requirement is good faith. Reports made maliciously or without reasonable basis are not protected. Institutional liability attaches when organizations fail to respond appropriately to impairment concerns. Healthcare facilities have duties to credential and supervise their practitioners, and failure to act on known or reasonably discoverable impairment can result in organizational liability under theories of negligent credentialing for granting or maintaining privileges despite known impairment, negligent supervision for failing to monitor or respond to concerning patterns, or respondent superior for vicarious liability for employee actions. These institutional liability theories provide additional incentive for robust organizational response to impairment concerns. Impairment-related information requires careful confidentiality management that balances privacy with safety. HIPAA protections apply to health information about the impaired practitioner as they would to any patient. Personnel records are typically confidential under institutional policy and employment law. IPN and PRN maintain confidentiality for compliant participants, with names not disclosed to the Department of Health unless participants fail to comply with monitoring agreements. However, confidentiality is not absolute. Patient safety interests can override privacy concerns when impairment poses ongoing risk, and reports to appropriate entities are necessary and appropriate uses of information. Remember this key point. Florida law mandates reporting of suspected impairment with penalties for failure to report while providing immunity protections for good faith reporters. Professional codes of ethics reinforce this duty with patient safety as the paramount concern. The question is not whether to act when impairment is suspected, but how to act appropriately to protect both patients and the affected colleague's opportunity for recovery. We now move to Module 7, which covers intervention strategies and Florida resources. When you have concerns about a colleague's impairment, the manner of your approach matters significantly for the outcome. Hostile confrontation or accusatory language typically produces denial, defensiveness, and sometimes counter-accusations that escalate conflict without advancing intervention. Compassionate concern expressed privately is more likely to result in acknowledgement of problems and acceptance of help. However, informal peer approaches have important limits and are not always appropriate. Consider a private, supportive conversation when concerns are early and relatively minor. When you have a trusting relationship with the colleague that provides credibility for your concern, when there is no immediate patient safety risk that requires urgent action, and when you believe the colleague may be receptive to feedback based on your knowledge of them. In such conversations, express genuine concern for the person as a person, not merely criticism of their work behavior. Focus on specific observations rather than interpretations or accusations. You might say something like, "I noticed you seemed unsteady yesterday and I have been worried about you." Ask open-ended questions such as, "Is everything okay? Is there anything I can help with?" Mention available resources like EAP without diagnosing the problem. Be prepared for denial, which should not be argued with in the moment. Escalate beyond peer conversation when the person denies obvious concerns and peer conversation has not changed behavior, when patient safety is at risk, which always requires action beyond peer conversation, when the situation involves potential diversion, falsification, or other policy violations that must be reported, or when the person's response suggests they need more help than a peer can provide. Escalation does not mean you failed. It means you recognize the limits of informal intervention and acted appropriately for patient safety and colleague well-being. Formal interventions typically involve structured conversations with multiple participants, coordinated through human resources, management, occupational health, or professional intervention specialists. These interventions present the individual with documented concerns across multiple observers and situations, explain consequences of continued behavior, and offer a clear pathway to treatment and recovery through programs like IPN or PRN. The goal is not punishment but treatment, and the message should convey that concern. You might communicate something like, "We are concerned about you. Your practice has been affected. We want to help you get the treatment you need. Here is what will happen if you choose to engage with help versus if you do not." The Intervention Project for Nurses, known as IPN, is Florida's designated Impaired Practitioner program for nurses, established in 1983 as the first alternative to discipline program in the nation. IPN operates under contract with the Florida Department of Health pursuant to Florida Statute 456.076 to provide education, support, and monitoring to nurses with impairing conditions including substance use disorders, psychiatric conditions, and physical conditions affecting practice. IPN serves as a national model and has been consulted by many other states developing their own programs. Regarding eligibility, IPN serves all Florida licensed nurses, including RNs, LPNs, and ARNPs, who have impairing conditions. Nurses may enter IPN through self-referral by contacting IPN directly before any formal complaint, through employer referral often as a condition of continued employment or as an alternative to termination, through Board of Nursing referral as part of a consent agreement resolving a licensing complaint, through treatment provider referral, or through referral by family members, colleagues, or others with knowledge of impairment. Self-referral before a complaint is filed may provide the most favorable pathway, as it demonstrates initiative and may avoid formal board involvement, though this depends on specific circumstances. The IPN process begins with an evaluation. Upon referral, nurses undergo evaluation by IPN-approved evaluators, typically psychiatrists or addiction medicine specialists with expertise in professional impairment, who assess diagnosis, severity, treatment needs, and recommendations for monitoring. Based on evaluation findings, IPN develops a monitoring agreement specifying treatment requirements including level of care, duration, and modalities. The agreement specifies testing frequency and protocols for random drug and alcohol testing, support group attendance requirements, which are typically weekly, practice restrictions, if any, such as no access to controlled substances or no night shifts, and duration of monitoring, which is typically 2 to 3 years for mental health conditions and 3 to 5 years for substance use disorders. IPN program components include weekly nurse support groups facilitated by trained facilitators who are often nurses in recovery themselves, providing peer support and accountability. Random drug and alcohol testing occurs at frequencies determined by diagnosis and program phase. Individual therapy and psychiatric medication management continue as indicated by clinical need. Treatment programs including outpatient, intensive outpatient, or residential, depending on need, provide primary treatment. Worksite monitors supervise return to practice when nurses are cleared to work, reporting to IPN on compliance with workplace restrictions and any concerning observations. Regarding confidentiality, for nurses who comply with their monitoring agreements, IPN maintains confidentiality as authorized by Florida Statute 456.076. Names are not reported to the Department of Health or Board of Nursing, and participation does not appear on public license verification databases. This confidentiality protection encourages participation, reduces stigma, and protects careers for those who engage successfully with recovery. However, confidentiality ends if participants fail to comply with their agreements. Missed tests, positive results, failure to attend required sessions, or return to practice violations trigger reporting to the board for potential disciplinary action. Regarding costs, participants are responsible for all program-related costs, including independent medical evaluations, which typically range from $2,000 to $5,000, treatment programs, which are variable from hundreds to tens of thousands of dollars depending on level of care, drug testing fees, therapy and psychiatric fees, support group fees, and IPN monitoring fees. These costs can be substantial. Some participants report spending $30,000 or more over a 3-year monitoring period. Participants should understand these financial obligations and plan accordingly, potentially including negotiation of payment plans with providers. For contact information, IPN can be reached at ipnfl.org or by telephone at 1-800-840-2720. The website provides detailed information about the referral process, approved evaluators, program expectations, and frequently asked questions. The Professionals Resource Network, known as PRN, serves physicians, pharmacists, physician assistants, dentists, podiatrists, and other non-nurse healthcare professionals under the same statutory authority as IPN found in Florida, Statute 456.076. PRN provides comparable services including evaluation, treatment coordination, monitoring, advocacy, and support for practitioners with impairing conditions. The Federation of State Physician Health Programs establishes standards for such programs nationally. PRN monitoring agreements are typically 5 years for substance use disorders, reflecting the evidence that physician health programs achieve their remarkable outcomes through extended monitoring that spans the high-risk early recovery period. Mental health conditions may have shorter monitoring periods depending on diagnosis and stability. Research from the Florida PRN program has reported 92% success rates for physicians who comply with their 5-year monitoring agreements. These outcomes far exceed general population recovery rates and demonstrate the effectiveness of intensive professional monitoring. The landmark research establishing physician health programs as the gold standard for addiction treatment documented 78% favorable outcomes at 5-year follow-up across multiple physician health programs nationally. These outcomes reflect the unique combination of factors present in professional monitoring programs. Participants have high motivation for recovery because career preservation provides powerful incentive. They typically have financial resources for high-quality treatment. They possess cognitive abilities supporting engagement with recovery concepts and programs. They receive structured accountability through random testing and regular check-ins. They have peer support from other recovering professionals who understand the specific challenges of healthcare practice. And they face consequences for non-compliance that provide external motivation during the difficult early recovery period. PRN maintains an active research program evaluating prevention, treatment, and monitoring of professionals with impairing conditions. This research contributes to evidence-based practices for physician health programs nationally and supports continuous quality improvement in PRN's own monitoring processes. Published research from PRN investigators has contributed significantly to the literature on healthcare professional impairment and recovery. For contact information, PRN can be reached at flprn.org or by telephone at 1-800-888-8776. The website provides information about referrals, the evaluation process, monitoring requirements, and available resources. Most healthcare employers offer employee assistance programs known as EAPs, providing confidential counseling, assessment, and referral services for employees experiencing personal or work-related problems. EAPs can be valuable first-line resources for employees experiencing stress, relationship difficulties, grief, anxiety, or early-stage substance use or mental health concerns before impairment affects practice. They provide accessible, employer-paid services that may identify problems early and facilitate appropriate treatment. However, EAPs have important limitations in the impairment context. EAP services are typically brief, usually 3 to 6 sessions, and focused on assessment and referral rather than treatment of serious conditions. EAPs do not provide the intensive long-term monitoring that IPN and PRN provide, and that evidence suggests is necessary for optimal outcomes in healthcare professional recovery. EAP confidentiality may be limited when safety concerns arise, and the specific limitations should be understood before relying on EAP confidentiality protections. An employee with moderate to severe impairment typically needs more than EAP can provide. EAPs are most appropriate for early intervention before impairment affects patient care, as a supplement to IPN or PRN monitoring for issues not directly related to the impairing condition, for support to family members affected by a colleague's impairment, for resources for those who have reported impaired colleagues and are experiencing stress as a result, and for general mental health support for healthcare workers experiencing occupational stress, burnout, or life transitions. Treatment for healthcare professionals with impairment varies based on diagnosis, severity, and individual circumstances. Levels of care include outpatient treatment with weekly therapy and medication management, intensive outpatient programs with 9 to 20 hours per week of structured programming while living at home, partial hospitalization programs with full-day programming while living at home, and residential treatment with 24-hour care for 30 to 90 days or longer. Some treatment programs specialize in healthcare professionals, understanding the unique circumstances of this population, including high cognitive function, complex motivations, professional consequences, and the specific stressors of healthcare practice. A study on peer recovery coach programs in emergency departments identified key implementation strategies, including streamlined communication between clinical staff and recovery coaches, addressing barriers to services such as transportation and insurance, and supportive supervision for coaches. These principles are applicable to supporting healthcare professionals in recovery as well. Physician perspectives on harm reduction for patients who use drugs identified facilitators, including institutional support and education, that could inform approaches to supporting impaired colleagues. Return to practice following treatment for impairment is not automatic, but requires demonstration of stability and clearance from IPN or PRN based on treatment completion, a period of demonstrated sobriety or symptom stability, fitness for duty evaluation when indicated, and readiness assessment considering the individual's specific clinical role. Practice may initially be restricted with limited hours, no access to controlled substances, no independent practice, or no night shifts. Restrictions are gradually lifted based on demonstrated stability over time. Worksite monitors play essential roles in supporting successful return to practice. Monitors are typically supervisors or senior colleagues at the returning practitioner's workplace who receive orientation from IPN or PRN about monitoring responsibilities, confidentiality requirements, and reporting procedures. They observe the returning practitioner for signs of relapse or difficulty, verify compliance with practice restrictions, provide supportive feedback, and communicate regularly with IPN or PRN case managers about the practitioner's workplace performance. Worksite monitoring continues for the duration of the monitoring agreement. The evidence strongly supports that healthcare professionals can recover from impairing conditions and return to safe, competent practice. The 78 to 92% success rates for compliant participants in professional monitoring programs demonstrate that intensive monitoring, peer support, and accountability create conditions for sustained recovery that far exceed general population outcomes. These outcomes are among the best in addiction medicine and reflect the value of structured professional monitoring programs. Remember this key point. Florida's IPN and PRN programs provide structured pathways to recovery with confidentiality protections for compliant participants, achieving success rates of 78 to 92% for those who engage fully with monitoring. These programs represent a national model for addressing healthcare professional impairment in ways that protect both patient safety and professional careers. Early referral before crisis produces the best outcomes. We now come to Module 8, which presents case studies for practical application of the concepts you have learned. Our first case study involves an experienced ICU nurse. Sarah is a 45-year-old ICU nurse with 20 years of excellent performance reviews. Over the past 6 months, colleagues notice she has become increasingly irritable and withdrawn. She frequently volunteers to care for patients with PCA pumps and has been observed making extra trips to the medication room. 3 of her patients in the past month have complained of inadequate pain relief despite documented administration of full pain medication doses. A newer nurse mentions that Sarah's wasting documentation seems unusual, but is not sure if she is just unfamiliar with unit practices. Sarah has recently been going through a difficult divorce and has mentioned back pain from a car accident 2 years ago. This case presents classic warning signs of opioid diversion as documented in research on controlled substance theft and diversion. Behavioral changes, including irritability and withdrawal, suggest distress. Patterns suggesting drug seeking include volunteering for patients with PCA pumps and extra trips to the medication room. Documentation concerns including patient complaints of inadequate relief and unusual wasting patterns noted by the newer nurse raise red flags for diversion through substitution or dilution. The contextual factors of divorce stress and chronic back pain provide potential explanations for both substance misuse onset and mood changes. Sarah's 20 years of excellent performance may make colleagues reluctant to suspect her, but experienced nurses actually have elevated diversion risk due to their knowledge, access, and potential development of tolerance from prior legitimate exposure. The newer nurse's observations about unusual wasting documentation are particularly significant. New employees often notice patterns that longer-tenured staff have normalized or learn not to question. The appropriate response is for the newer nurse's observations and the patient complaints to be reported to the supervisor and pharmacy for review of Sarah's controlled substance handling patterns. This is not personal investigation, but appropriate escalation to those with authority and resources to investigate. If medication discrepancies are confirmed, the employer will typically conduct a formal investigation, which may include review of automated dispensing cabinet records, comparison of Sarah's patterns to peers, and drug testing. If substance use disorder is confirmed, referral to IPN offers a pathway to treatment while protecting Sarah's license if she complies with monitoring. Our second case study involves a resident physician in crisis. Marcus is a third-year internal medicine resident who was previously known for his energy, dedication, and exceptional patient rapport. Over the past 2 months, attendings have noted he seems exhausted beyond normal residency fatigue, has difficulty making decisions even on familiar cases, and has been tearful when questioned about minor issues. He has called in sick 3 times, which is unusual for someone who previously never missed a day. Yesterday, a patient's wife complained that Dr. Marcus seemed out of it during afternoon rounds and did not remember a conversation from that morning. When a concerned co-resident asks if he is okay, Marcus says he is fine, but admits he has not been sleeping well, feels overwhelmed, and lately feels like nothing matters anymore. This case raises serious concerns for depression with possible suicidal ideation. The phrase "nothing matters anymore" is concerning for anhedonia, which is loss of ability to experience pleasure or meaning, and potentially for passive suicidal ideation. The combination of exhaustion beyond normal levels, indecisiveness, which is a cognitive symptom of depression, tearfulness indicating emotional dysregulation, increased absences suggesting withdrawal and possible inability to function, memory difficulties indicating cognitive impairment from depression or sleep deprivation, and the concerning statement requires immediate escalation beyond peer support. Research documents high prevalence of depression, burnout, and suicidal ideation among physicians and residents. The appropriate response is to express genuine concern to Marcus directly. You might say something like, "I am worried about you." When you say nothing matters anymore, I need to ask, are you having thoughts of hurting yourself? Direct questions about suicide do not increase risk and may open vital conversation. Regardless of Marcus's response, this situation requires escalation to the residency program director, designated wellness officer, or physician well-being program. Residents have elevated suicide risk, and the barriers to help seeking are particularly acute for physicians in training who fear academic consequences. Marcus needs professional evaluation and support, potentially through PRN if substance use is involved or through the residency's wellness resources if the primary issue is depression. Our third case study involves an aging pharmacist. Dr. Chen is a 68-year-old pharmacist with a distinguished 40-year career, multiple awards, and deep respect from colleagues. Recently, technicians have noticed he asks the same questions repeatedly within short time periods, occasionally dispenses incorrect medications which are caught by safety checks before reaching patients, and has difficulty operating the computer system despite years of proficiency. He became lost in the building one morning and seemed confused when a technician found him near an exit he never uses. When the pharmacy manager gently mentions her concerns, Dr. Chen becomes defensive, insists he is just tired from a new blood pressure medication his doctor prescribed, and notes that everyone makes mistakes sometimes. This case presents signs of cognitive impairment that may indicate early dementia or another neurodegenerative process. Key observations include memory problems demonstrated by repetitive questions, dispensing errors representing a change from baseline, difficulty with previously routine tasks such as computer operation, spatial disorientation from getting lost in a familiar building, and defensiveness when concerns are raised. This defensiveness may reflect either lack of insight known as anosognosia, which is common in dementia, or defensive minimization. While Dr. Chen attributes changes to a new medication, and medication effects should be considered, the pattern of multiple cognitive domains affected, spatial disorientation, and functional decline suggests evaluation for possible neurodegenerative disease is warranted. The blood pressure medication might contribute to symptoms, but is unlikely to fully explain this presentation. Research on physician cognitive assessment indicates that age-corrected norms for the general population may not identify impairment in physicians who have baseline cognitive abilities well above population average. The appropriate response is for the pharmacy manager to document specific observations with dates and details, then escalate to human resources or the medical director for institutional guidance. A fitness for duty evaluation by occupational medicine, with neuropsychological testing and medical workup for reversible causes of cognitive change, can assess whether Dr. Chen can safely continue practicing with or without accommodations. If cognitive impairment is confirmed, PRN may coordinate evaluation and support transition planning. The goal is to protect patients while treating Dr. Chen with the dignity his career merits, which may include supported transition to retirement if continued practice is not safe or practice modifications if partial function is preserved. Our fourth case study involves your best friend at work. Jennifer is your closest friend at work. You have been colleagues for 10 years, attended each other's weddings, and consider each other family. Recently, you have noticed her breath smells of alcohol during afternoon shifts. She has called you to cover for her when she was running late several times in the past month, something that never happened before. Last week, she confided that her husband left her. She has been drinking more than she should just to cope and get some sleep, and she is worried about her kids. She begged you not to tell anyone and promised she would cut back. She said she knows she needs help, but is terrified of losing her license and her ability to support her children. Today, you smell alcohol on her breath again during your shift together. This case illustrates the painful reality that impairment reporting obligations extend to friends and colleagues we care about deeply. Jennifer's pattern includes alcohol odor at work today, and not just once, requesting coverage with increasing frequency, admitted excessive drinking beyond her control, a broken promise to reduce use, and fear of consequences preventing self-referral. This pattern indicates an alcohol use problem that is currently affecting her ability to practice safely. Your loyalty to Jennifer and concern for her well-being and her children cannot override your duty to patients she is currently caring for while impaired. Jennifer's fear of licensing consequences, while understandable, is precisely why IPN exists, to provide a confidential pathway to treatment that protects licenses for those who comply rather than the punitive discipline she fears. By not seeking help, Jennifer is actually increasing her risk of the outcomes she fears. If she harms a patient or is caught impaired, the consequences will be far more severe than voluntary IPN participation. The appropriate response is as follows. If Jennifer is acutely impaired today, which is evidenced by alcohol odor on breath, she cannot continue providing patient care. This requires immediate action. Inform the supervisor that Jennifer needs to be removed from patient care today. This is a patient safety issue that cannot wait. Then, ideally before or during the employer investigation, encourage Jennifer to self-refer to IPN immediately, explaining that self-referral before a complaint provides the best pathway. You can express your love and concern by saying something like, "I am doing this because I care about you and your kids. I do not want you to hurt a patient or lose everything. IPN can help you keep your license while you get treatment." Be prepared for Jennifer's anger and potentially the loss of your friendship, at least temporarily. Many relationships recover once the person is in recovery and can recognize that reporting came from love, not betrayal. Our fifth case study involves a burned-out nurse practitioner. Amanda is a 38-year-old family nurse practitioner who has worked in a busy primary care clinic for 7 years. She was always known for her warmth, thoroughness, and genuine connection with patients. Over the past year, the clinic has experienced significant staff turnover, increasing her patient load from 18 to 28 patients per day. Colleagues notice she now seems emotionally flat during patient interactions, rushes through visits, and has started making dismissive comments about frequent flyer patients with chronic conditions. She recently snapped at a medical assistant who asked a routine question, then apologized profusely and started crying in the break room. Her documentation has become increasingly brief and templated. She confides to a colleague that she does not care anymore and fantasizes about quitting healthcare entirely. She has been drinking wine every night just to unwind and admits she has gained 20 pounds because she is too exhausted to exercise or cook. Her patient satisfaction scores have dropped significantly over the past 2 quarters. This case illustrates burnout progressing toward more serious impairment, with emerging signs of compassion fatigue, possible depression, and early problematic alcohol use. Research documents burnout prevalence of 30 to 60% among healthcare providers, with the COVID-19 pandemic and ongoing staffing crises exacerbating an already serious problem. Amanda's presentation shows classic burnout dimensions, including emotional exhaustion from feeling drained, crying, and fatigue, depersonalization from dismissive comments about patients and emotional flatness, and reduced personal accomplishment from brief documentation and fantasies of leaving healthcare. The statement "does not care anymore" is concerning for both burnout-related depersonalization and possible depression. Her nightly alcohol use to unwind represents a common but maladaptive coping pattern that can progress to alcohol use disorder, particularly when combined with chronic stress and emerging depression. The weight gain and inability to maintain self-care activities suggest her coping capacity is overwhelmed. Declining patient satisfaction scores provide objective evidence that her condition is affecting patient care quality. The appropriate response involves a multi-level approach addressing both individual and systemic factors. At the individual level, a trusted colleague or supervisor should have a private, supportive conversation expressing genuine concern for Amanda's well-being, rather than criticism of her performance. This conversation should explore whether she has considered speaking with a therapist or her own physician about how she is feeling, and should mention EAP resources. The alcohol use pattern should be gently explored. If it is progressing, earlier intervention through IPN consultation may be warranted. At the organizational level, Amanda's situation reflects systemic problems that cannot be solved through individual intervention alone. Research shows that organizational factors, including leadership support, adequate staffing, and reasonable workload expectations, significantly impact burnout and mental health outcomes. The clinic's staffing issues and increased patient loads are contributing factors that leadership should address. Amanda may benefit from temporary workload reduction, protected time for self-care, or even a brief leave of absence to prevent progression to more serious impairment. If her condition continues to deteriorate despite support, or if alcohol use escalates, formal referral to IPN may become necessary. Our 6th case study involves an emergency department physician with PTSD. Dr. Rodriguez is a 52-year-old emergency medicine physician with 20 years of experience who has always been known as unflappable in crisis situations. During the COVID-19 pandemic surge, he worked extended hours in a hospital that was overwhelmed, making difficult triage decisions about ventilator allocation and witnessing unprecedented numbers of deaths, often with families unable to be present. 18 months later, colleagues notice he has become hypervigilant and jumpy, startling dramatically at routine overhead pages and monitor alarms. He has requested to work only day shifts and becomes visibly anxious when asked to cover nights. He avoids caring for patients with respiratory complaints when possible, deferring to colleagues. He has been irritable with staff and had an uncharacteristic outburst at a nurse who questioned an order. His wife called the department director concerned that he wakes with nightmares several times per week, has become emotionally distant from the family, and has been drinking more heavily. He refuses to discuss the COVID days and becomes agitated if colleagues bring up pandemic experiences. Dr. Rodriguez presents with classic symptoms of post-traumatic stress disorder following occupational trauma exposure. Research documented PTSD prevalence of over 25% among hospital healthcare workers during the COVID-19 pandemic. His presentation includes intrusive symptoms in the form of nightmares, avoidance by refusing to discuss the pandemic, avoiding respiratory patients, avoiding night shifts when the hospital was most overwhelmed, negative alterations in cognition and mood shown by emotional distance from family, and hyperarousal including hypervigilance, exaggerated startle response, irritability, and an angry outburst. The moral injury component of his experience, making ventilator allocation decisions that determined who would live and die, adds a dimension that may not fully respond to standard PTSD treatment and requires specialized approaches. His wife's report of increased alcohol use is particularly concerning, as the co-occurrence of PTSD and alcohol use disorder is common. Research showed that over 25% of hospital healthcare workers during COVID showed problematic alcohol or substance use, and each condition worsens the other. His avoidance of respiratory patients and night shifts, while understandable, represents functional impairment that limits his clinical capacity and places additional burden on colleagues. The appropriate response is that Dr. Rodriguez needs professional mental health treatment from providers experienced with occupational trauma and moral injury, ideally someone who understands healthcare culture and the specific stressors of emergency medicine. The department director should have a private, compassionate conversation acknowledging the extraordinary circumstances Dr. Rodriguez endured and expressing concern for his current well-being. This is not a punitive conversation. It is recognition that someone who gave everything during a crisis is now struggling with the aftermath. If Dr. Rodriguez is receptive, EAP referral or connection to physician wellness resources may facilitate entry to treatment. If alcohol use has progressed significantly, PRN consultation may be appropriate to determine whether formal monitoring is indicated. Accommodations such as temporary schedule modifications may be reasonable while he engages with treatment, but persistent avoidance of core clinical duties like caring for respiratory patients in an ED would represent impairment requiring more definitive intervention. The second victim phenomenon research emphasizes that healthcare workers involved in traumatic events, including the collective trauma of the pandemic, require institutional support to prevent cascading effects. Our seventh case study involves a surgical technician using stimulants. Derek is a 29-year-old surgical technician who has worked in the operating room for 4 years. He is known for his energy, efficiency, and ability to anticipate surgeon needs. He recently started working extra shifts to pay off student loans and save for a wedding. Colleagues notice he now seems wired, talking rapidly, appearing restless between cases, and becoming irritable when cases run slowly. He has lost noticeable weight over the past few months. A circulating nurse observes that his hands seem to tremble slightly when he is setting up instruments, though his technical skills during cases remain precise. He has been making frequent trips to the bathroom and seems to have a constant runny nose that he attributes to allergies. He was found in the break room at 3 a.m. during an on-call shift, wide awake and reorganizing supply cabinets, something no one asked him to do. When a colleague jokingly asks if he is on something, Derek becomes defensive and angry, accusing the colleague of being jealous of his work ethic. This case presents warning signs consistent with stimulant use, potentially amphetamines or cocaine. The constellation of symptoms includes hyperactivity and rapid speech, weight loss, tremor, irritability, rhinorrhea or runny nose, which is consistent with intranasal drug use, sleep pattern abnormalities from being awake and active at 3 a.m., and defensive anger when questioned. Unlike opioid impairment, which typically produces sedation and slowing, stimulant intoxication may initially enhance performance before tolerance develops and use escalates. Derek's technical skills remain intact even as behavioral changes emerge. The context is significant. Derek is working extra shifts for financial reasons and may have initiated stimulant use to maintain energy and performance across an unsustainable schedule. This pattern of using substances to meet demanding work expectations is recognized among healthcare workers across professions. His defensiveness when questioned, framed as others being jealous of his work ethic, represents both denial and rationalization characteristic of early-stage substance use disorders. The operating room environment adds specific concerns. While Derek's technical performance currently appears intact, stimulant use affects judgment, impulse control, and fine motor steadiness in ways that could compromise patient safety during critical moments. Stimulant intoxication or withdrawal during a case could impair his ability to respond appropriately to emergencies. Additionally, working in an environment with access to controlled substances while having an active substance use disorder creates diversion risk, even if his current substance of abuse is obtained outside the workplace. The appropriate response is that the observations described should be reported to the OR manager or appropriate supervisor for investigation. This is not about a single incident, but a pattern of behavioral changes, physical signs, and concerning circumstances, including being awake at 3 a.m. and having a defensive reaction to questioning that collectively suggest possible substance use. An objective workplace drug test may provide clarity. If stimulant use disorder is confirmed, Derek would be eligible for IPN as a surgical technician working under nursing supervision, or potentially another pathway depending on his specific licensure. The financial pressures driving his extra shifts should be considered in treatment planning. Recovery will be difficult if the underlying stressors remain unaddressed. Research on alternative to discipline programs identifies that effective intervention addresses not only the substance use itself, but contributing factors including workplace conditions and life circumstances. Derek is young in his career, and early intervention offers the best chance for sustained recovery and a long career in surgical services. Our eighth case study involves a nurse anesthetist with benzodiazepine dependence. Christina is a 44-year-old certified registered nurse anesthetist who has practiced for 15 years with an excellent safety record. She began taking alprazolam prescribed by her physician 3 years ago for panic attacks that developed after a serious anesthesia complication in which a patient nearly died. The medication helped initially, but over time she needed higher doses and began taking extra doses before particularly stressful cases. She recently started obtaining additional benzodiazepines from an online pharmacy and from a colleague who had leftover medication after a dental procedure. Colleagues have noticed she sometimes seems slightly sedated during the first case of the day, with mildly slurred speech and slowed responses, though she wakes up as the morning progresses. She has become forgetful, sometimes asking the same questions repeatedly in pre-op. A surgeon complained that she seemed out of it during a recent case and was slow to respond when the patient's blood pressure dropped. Christina has tried to stop the medication several times, but experiences severe anxiety, tremors, and insomnia that make her feel she cannot function without it. She tells herself she is managing a legitimate medical condition and that her use is different from addiction. This case illustrates benzodiazepine dependence that developed from legitimate therapeutic use, a common pathway to substance use disorder among healthcare professionals. Christina's initial prescription for panic attacks following a traumatic workplace event was clinically appropriate, but tolerance development, dose escalation, obtaining medications through irregular channels including an online pharmacy and a colleague, and continued use despite concerning symptoms such as sedation, affecting work, cognitive impairment, and surgeon complaints indicate progression to substance use disorder. The physical signs of sedation in the morning that improves as the day progresses likely reflect intoxication from doses taken before work, with improvement as the drug is metabolized. Alternatively, or additionally, she may be experiencing interdose withdrawal that is relieved by her next dose. Her cognitive symptoms, including forgetfulness and repeating questions, are consistent with benzodiazepine effects on memory encoding. The surgeon's complaint about slow response during a blood pressure drop is particularly alarming. In anesthesia, delayed response to physiologic changes can be catastrophic. Christina's rationalization that she is managing a legitimate medical condition and is different from addiction reflects the cognitive distortions common in healthcare professionals with substance use disorder. Her attempts to stop, followed by severe rebound anxiety, tremors, and insomnia, confirm physiological dependence. Importantly, benzodiazepine withdrawal can be medically dangerous. Unlike opioid withdrawal, which is extremely uncomfortable but rarely life-threatening, benzodiazepine withdrawal can cause seizures and requires careful medical management. The appropriate response is that the surgeon's complaint and colleagues' observations of sedation provide concrete concerns that should be reported to the chief CRNA, anesthesia director, or appropriate supervisor. Given the safety-critical nature of anesthesia practice, even modest impairment poses unacceptable patient risk. Christina should not continue providing anesthesia care while showing signs of intoxication. When approached, Christina may be more receptive to intervention than colleagues expect. Her failed attempts to stop suggest she recognizes she has a problem but does not know how to address it safely. She should be informed that benzodiazepine discontinuation requires medical supervision due to withdrawal risks and that IPN can coordinate appropriate evaluation and treatment. Treatment will likely involve gradual medically supervised taper, treatment of the underlying anxiety disorder through non-benzodiazepine approaches, including therapy and alternative medications, and monitoring through IPN. The original trauma from the anesthesia complication may also warrant PTSD treatment. With appropriate intervention, Christina can recover and potentially return to anesthesia practice under monitoring, though she may face practice restrictions regarding her own access to controlled substances. Our ninth and final case study involves a physical therapist with chronic pain. Michael is a 51-year-old physical therapist who has worked in an outpatient orthopedic clinic for 18 years. 5 years ago, he sustained a significant back injury while transferring a patient and has had chronic pain since, despite 2 surgeries. He has been on long-term opioid therapy prescribed by a pain management physician, currently taking oxycodone extended release twice daily plus immediate release oxycodone for breakthrough pain. Over the past year, his pain has worsened despite dose increases, and he has been using his breakthrough medication more frequently than prescribed, running out early each month. He has called in sick on days when he runs out of medication, citing back flare-ups. Colleagues notice he sometimes seems drowsy in the afternoon, moves stiffly, and has reduced his hands-on treatment time with patients, relying more heavily on exercise prescription and modalities. He has asked colleagues to cover transfers and manual therapy for larger patients. Patient outcomes data show his patients are progressing more slowly than those of his colleagues. He becomes defensive when his supervisor suggests he may need to consider whether his physical limitations are affecting his practice, insisting he is fine and accusing her of age discrimination. This case presents the complex intersection of chronic pain, opioid therapy, possible opioid use disorder, and physical limitations affecting practice. Michael's situation illustrates how legitimate medical treatment can evolve into impairment through multiple mechanisms. His physical limitations from the back injury affect his ability to perform essential job functions, including transfers and manual therapy. His opioid use has escalated beyond prescribed parameters, using breakthrough medication more frequently than prescribed, and running out early, suggesting possible opioid use disorder superimposed on chronic pain. The drowsiness observed by colleagues suggests possible oversedation from opioids. His defensive response to concerns reflects both the stigma associated with opioid use and possible lack of insight into his functional decline. The distinction between disability and impairment is particularly relevant here. Michael's chronic pain condition and physical limitations might be considered a disability potentially eligible for reasonable accommodation under the ADA. However, accommodation analysis requires determining whether he can perform essential job functions. If transfers and manual therapy are essential functions of his position, as they typically are for outpatient orthopedic physical therapists, his current limitations may constitute impairment regardless of their etiology. Additionally, if his opioid use has progressed to a use disorder, that represents a separate impairment requiring intervention. The patient outcomes data showing slower progress compared to colleagues provides objective evidence that his condition is affecting patient care. This removes the question from the realm of subjective judgment about whether he seems impaired and grounds it in measurable impact on the quality of care patients receive. The appropriate response requires a multifaceted approach addressing both the physical limitations and the potential opioid-related concerns. The supervisor's initial conversation was appropriate, though Michael's defensive response prevented productive dialogue. A more formal meeting, potentially including human resources and occupational health, should address the objective concerns including patient outcomes data, observed functional limitations, attendance pattern when medications run out, and colleagues' observations of drowsiness. A fitness for duty evaluation can objectively assess Michael's capacity to perform essential job functions and may include both physical functional capacity evaluation and assessment of his opioid use pattern. If opioid use disorder is identified, PRN referral would be appropriate since physical therapists are covered under PRN rather than IPN. Treatment might include evaluation for alternative pain management approaches, possible opioid taper with transition to non-opioid pain management or medication-assisted treatment if appropriate, and treatment of any underlying depression or anxiety contributing to his pain experience. Regarding his physical limitations, if Michael cannot safely perform essential job functions even with reasonable accommodation, options might include transitioning to a role with different physical demands such as consultation, utilization review, or education. A temporary disability leave while pursuing additional treatment might be appropriate. In some cases, medical retirement may be necessary. The goal is to be honest about his current limitations while exploring every possible pathway to continued contribution to health care. His 18 years of experience represent valuable expertise that might be preserved in an appropriately modified role, even if he cannot continue direct patient care in his current capacity. Remember this key point from these case studies. Real-world impairment situations are complex, emotionally charged, and often involve people we know and care about. Applying the principles from this course requires both knowledge and courage. Patient safety must guide decisions, but compassion for affected colleagues can and should inform how we act. Early intervention through IPN and PRN produces far better outcomes than waiting for crisis. Let us now conclude with a summary of the key takeaways from this course. This course has covered the essential knowledge and skills needed to recognize and respond to impairment in healthcare colleagues. The following key points summarize the core content. Impairment is a treatable condition with excellent outcomes when appropriate intervention occurs. Healthcare professionals who engage with monitoring programs like IPN and PRN achieve recovery rates of 78 to 92% at 5-year follow-up. These outcomes far exceed general population recovery rates. Early intervention, before crisis and before patient harm, produces the best outcomes for everyone involved. The shift from punitive to rehabilitative approaches, pioneered in Florida with the 1983 establishment of IPN, has proven both more humane and more effective than traditional discipline. The 4 major categories of impairment, including substance use disorders, mental health conditions, physical impairments, and cognitive decline, frequently overlap and interact. All can compromise patient safety when they affect clinical practice. Understanding each category, including its neurobiological basis, occupational risk factors, and clinical manifestations, enables recognition and appropriate response. Recognition requires attention to patterns rather than single incidents. Behavioral changes, physical signs, performance deficits, and documentation irregularities should be documented objectively and evaluated in context over time. When patterns suggest impairment, action is warranted even without certainty about the underlying cause. Differential considerations are important, but patient safety requires action when concerning patterns emerge. Florida law mandates reporting of suspected impairment and provides immunity protections for good faith reporters. Professional codes of ethics reinforce this duty. Patient safety takes precedence over colleague loyalty, but alternative to discipline programs provide pathways to recovery that protect both patients and practitioner careers for those who engage with treatment and monitoring. IPN and PRN provide structured pathways to recovery with confidentiality protections for compliant participants. These programs, operating under Florida Statute 456.076, represent a national model for addressing healthcare professional impairment. Self-referral before a formal complaint often provides the most favorable pathway. The 92% success rate for compliant PRN participants demonstrates that recovery is not only possible but expected with appropriate structure and support. Here are the key resources available to you. The Intervention Project for Nurses, IPN, can be reached at ipnfl.org or by calling 1-800-840-2720. The Professionals Resource Network, PRN, can be reached at flprn.org or by calling 1-800-888-8776. The SAMHSA National Helpline is available at 1-800-662-4357 and provides 24/7 treatment referral service. The 988 Suicide and Crisis Lifeline is available by calling or texting 988. The Dr. Lorna Breen Heroes Foundation can be found at drlornabreen.org. The Florida Department of Health can be found at floridahealth.gov. This concludes our course on recognizing impairment in the workplace for Florida healthcare professionals. Thank you for your commitment to patient safety, to supporting colleagues who may be struggling, and to maintaining the integrity of your profession. The knowledge you have gained today may one day help you save a colleague's career and, more importantly, protect patients from harm. Remember that recognition and intervention are not acts of betrayal. They are acts of professional responsibility and compassionate concern. When you see something, say something. Florida's IPN and PRN programs exist to provide pathways to recovery, and early referral produces the best outcomes for everyone involved. We will now review the exam questions to solidify your understanding of key concepts from this course on recognizing impairment in the workplace for Florida healthcare professionals. Question 1. What are the 4 major categories of impairment affecting healthcare professionals? The correct answer is C. Substance use disorders, mental health conditions, physical impairments, and cognitive impairments. Rationale: these 4 categories represent the comprehensive framework for understanding impairment in healthcare settings. Substance use disorders encompass alcohol and drug dependence. Mental health conditions include depression, anxiety, and post-traumatic stress disorder. Physical impairments cover sensory deficits, mobility limitations, and chronic pain conditions. Cognitive impairments result from neurodegenerative diseases, traumatic brain injuries, or age-related cognitive decline. Understanding these distinct categories helps healthcare professionals recognize the diverse ways impairment may manifest in colleagues, while also acknowledging that these categories frequently overlap, particularly in cases of dual diagnosis. Question 2. According to research on physician health programs cited in this course, what percentage of physicians have favorable outcomes at 5-year follow-up? The correct answer is D, 78%. Rationale: this statistic comes from landmark research examining the effectiveness of physician health programs nationwide. The 78% success rate at 5-year follow-up represents a significant achievement in treating healthcare professionals with impairment. It is worth noting that some individual programs report even higher success rates. For example, Florida's Professionals Resource Network reports success rates as high as 92% for participants who remain compliant with their monitoring agreements. However, the generally cited research figure across physician health programs is 78%, which demonstrates that with proper intervention and support, the majority of impaired healthcare professionals can successfully return to safe practice. Question 3. Which of the following is a behavioral indicator of potential impairment in a healthcare colleague? The correct answer is B. Increased conflict with coworkers and withdrawal from team activities. Rationale: behavioral changes are often among the earliest observable signs of impairment in healthcare colleagues. Increased interpersonal conflict, withdrawal from previously enjoyed team activities, isolation from colleagues, inappropriate emotional reactions, and defensiveness when questioned about well-being or work performance all represent concerning behavioral patterns. These changes may signal that a colleague is struggling with an impairing condition. In contrast, working extra shifts, asking questions about unfamiliar procedures, and requesting vacation time are generally normal workplace behaviors and should not be interpreted as indicators of impairment on their own. Recognizing the distinction between normal variations in behavior and concerning patterns is essential for appropriate identification of colleagues who may need assistance. Question 4. Under Florida law, what is the reporting threshold for suspected practitioner impairment? The correct answer is A. Reasonable suspicion. Rationale: Florida law sets the threshold for reporting at reasonable suspicion, which is an important distinction from higher standards such as certainty or proof. Healthcare professionals are not expected to diagnose their colleagues, conduct formal investigations, or gather definitive evidence before making a report. The standard is based on what a reasonable professional would conclude from their available observations. This threshold exists because waiting for absolute certainty before reporting could result in patient harm during the delay. The reasonable suspicion standard empowers healthcare professionals to act on their professional judgment and genuine concern, while leaving the formal evaluation and determination of impairment to qualified assessors and regulatory authorities. Question 5. When was Florida's Intervention Project for Nurses, also known as IPN, established, making it the first alternative to discipline program in the nation? The correct answer is D. 1983. Rationale. On October 1, 1983, the Florida legislature made history by establishing the Intervention Project for Nurses, creating the nation's first alternative to discipline program for healthcare professionals with impairment. This pioneering program recognized that disciplinary action alone was often ineffective at protecting public safety and rehabilitating impaired nurses. By offering an alternative pathway focused on treatment, monitoring, and support, IPN established a model that has since been adopted and adapted by states throughout the country. Over 4 decades of operation, IPN has continually evolved to incorporate emerging evidence-based practices and has demonstrated the effectiveness of the alternative to discipline approach for nursing professionals. Question 6. What is the most appropriate initial response when you have early concerns about a colleague's impairment? There is no immediate patient safety risk, and you have a trusting relationship with them. The correct answer is C. Have a private, supportive conversation expressing genuine concern. Rationale. When impairment concerns are in their early stages, no immediate threat to patient safety exists, and you have an established trusting relationship with the colleague, a direct and compassionate conversation represents the appropriate first step. This approach involves expressing genuine concern for the colleague's well-being, focusing on specific observable behaviors rather than making accusations or diagnoses, and informing them about available resources, such as employee assistance programs or the state's alternative to discipline programs. This supportive intervention may encourage a colleague to seek help before their condition progresses to a point where patient safety is compromised or formal reporting becomes necessary. However, if concerns persist after this conversation, if the colleague becomes defensive and refuses to acknowledge the issue, or if patient safety becomes threatened at any point, escalation through appropriate reporting channels is warranted. Question 7. Which Florida program serves physicians, pharmacists, and other non-nurse healthcare professionals with impairing conditions? The correct answer is B. Professionals Resource Network, also known as PRN. Rationale. Florida operates 2 distinct alternative to discipline programs under the same statutory authority, Florida Statute 456.076. The Intervention Project for Nurses, or IPN, serves registered nurses, licensed practical nurses, and advanced practice nurses specifically. The Professionals Resource Network, or PRN, serves all other healthcare professionals, including physicians, pharmacists, physician assistants, dentists, and podiatrists. Both programs offer confidential evaluation, treatment referral, and monitoring services that allow healthcare professionals to address their impairment while protecting their license and career. Employee assistance programs, while valuable resources for general counseling and support services, do not provide the specialized long-term monitoring and regulatory coordination that PRN and IPN offer. Understanding which program serves which professional group is essential for making appropriate referrals. This concludes the exam review. You should now have a stronger understanding of the key concepts that will appear on the examination. Remember that recognizing impairment in healthcare colleagues is both a professional obligation and an opportunity to support a colleague's recovery while protecting patient safety. Question 8. Which of the following patterns in medication handling would be a warning sign for potential drug diversion? The correct answer is D. Patients repeatedly complaining of inadequate pain relief despite documented full-dose administration. Rationale. This pattern represents one of the most reliable clinical indicators of potential drug diversion. When patients consistently report that their pain medication is not providing adequate relief, yet documentation shows they received the full prescribed dose, this discrepancy suggests the medication may have been tampered with before administration. Healthcare workers who divert controlled substances often substitute saline or diluted solutions for the actual medication or remove a portion of the drug for personal use while documenting the full dose was given. The result is that patients receive inadequate or no therapeutic effect despite appearing to receive appropriate treatment on paper. In contrast, following standard wasting procedures, maintaining consistent documentation, and having patients report adequate pain relief all represent normal and appropriate medication handling practices. Question 9. Burnout is characterized by which 3 dimensions? The correct answer is A. Emotional exhaustion, depersonalization, and reduced sense of personal accomplishment. Rationale. Burnout is recognized as an occupational syndrome rather than a medical diagnosis, and it is defined by these 3 specific dimensions. Emotional exhaustion refers to feeling completely drained and unable to face another workday, as though one has nothing left to give. Depersonalization manifests as cynical, detached attitudes toward patients who may be treated as objects or cases rather than as human beings deserving of compassionate care. Reduced sense of personal accomplishment involves feeling that one's work is meaningless or ineffective, leading to questions about whether the effort invested in healthcare work actually matters. Understanding these three dimensions helps healthcare professionals recognize burnout in themselves and colleagues before it progresses to more severe impairment or leads to patient care errors. Question 10. For nurses who comply with their IPN monitoring agreements, what happens regarding confidentiality? The correct answer is B. Their names are not reported to the Department of Health and participation does not appear on public license verification databases. Rationale. Confidentiality protection is a cornerstone of Florida's alternative to discipline model and serves several important purposes. For nurses who engage with IPN and comply with their monitoring agreements, Florida Statute 456.076 authorizes the program to maintain strict confidentiality. This means that participants' names are not reported to the Department of Health or the Board of Nursing, and their participation in the program does not appear when employers or the public search license verification databases. This confidentiality protection encourages nurses to seek help voluntarily, reduces the stigma associated with seeking treatment for impairment, and protects the careers of healthcare professionals who successfully engage with recovery. However, it is essential to understand that this confidentiality protection ends if participants fail to comply with their monitoring agreements, at which point the case may be referred for formal disciplinary action. This concludes the exam review. Remember that recognizing impairment in healthcare colleagues is both a professional obligation and an opportunity to support a colleague's recovery while protecting patient safety.